ECC Fellow Education. Good morning, everyone, and thank you for joining the Iowa ACC Fellow Education Lecture Series. In the past years, we were focused on other topics. This year, we are doing Advanced Imaging Lecture Series, and today we are going to start off with cardiovascular CT lectures. As a reminder, please keep your microphones muted at all times. Please communicate with the chat. Use the chat box for any questions or anything that you have. Joining me today in this conference today is our PIT Council leaders. We have Michael and Sapide, who are going to be moderating your questions in the chat at the end. Sapide is also the Chief Fellow in her program, so we're glad she's here. And without further delay, I'm going to go ahead and introduce our first speaker for the day, Dr. Paul Creamer. Dr. Paul Creamer is a cardiologist in the section of the cardiovascular imaging and an associate director of the Cardiac Intensive Care Unit and Associate Director of the Cardiovascular Medicine Training Program in the Robert and Suzanne Tomish Department of Cardiovascular Medicine at Cleveland Clinic main campus. He did his bachelor's in molecular biology from Princeton University and his medical degree from Harvard Medical School in Boston. Following completion of his internal medicine residency at Mass General Hospital, he worked as a physician for 2 years at the Navajo Shinle Comprehensive Healthcare Facility in Shinle, Arizona. He then continued his postdoctoral training with a 3-year fellowship in cardiovascular medicine and the subsequent 2-year fellowship in advanced cardiovascular imaging, both at the Cleveland Clinic, and he has been on the staff at the Cleveland Clinic since 2017. Dr. Creamer has co-authored more than 100 research papers in medical journals, including the New England Journal of Medicine, Circulation, JACC, and European Heart Journal. He has also authored several book chapters related to valvular heart disease, endocarditis, pericarditis, and myocardial perfusion imaging. He has presented his research and given lectures at numerous national and international meetings, including AHA, ACC, ASNAC, ASC, European Society of Cardiology, and European Society of Cardiovascular Imaging. He also serves as an associate editor for Circulation and Cardiovascular Imaging. In his leisure time, after doing all these activities, Dr. Creamer enjoys swimming, reading, and spending time with family. We understand his busy schedule and appreciate him taking his time to present to us about introduction to CT in procedural and surgical planning. Over to you, Dr. Creamer. Thank you.
Excellent. Thanks so much for that kind introduction and the opportunity to speak with you today. As you said, I did 5 years of training in cardiology and then cardiovascular imaging at the Cleveland Clinic, and I've been on staff. This is now going into my 5th year. And I would say even during that time, there's been a dramatic increase in the use of cardiac CT for many different clinical indications. So I think more and more, it really will become a foundational component, if you will, of general cardiovascular medicine training. And that's really the focus of this lecture, is for the cardiology fellows and the general cardiologist to have a sense of what questions we can answer with cardiac CT and how we might go about doing that in terms of how we build our protocols. So what I'd like to do in this lecture is really just 2 objectives. First, I think it's helpful for us to think about what the basic building blocks are as we're designing a CT protocol. And then, as I mentioned, how does that protocol inform our decision-making for specific clinical question, and I'll be focusing on questions related to intervention or cardiac surgery. What I won't cover, and some of this will be covered later in the session, is the increasing role of coronary CT angiography and calcium scoring. I won't touch upon acute aortic syndromes and planning endovascular aortic repair, and also complex congenital heart disease, because that just ends up being a bit too broad to try and cover in an hour. Okay, so how do I approach it? So what I tell the fellows is, when you're building a CT protocol, there's really 4 components that you need to think about. What is the field of view? Do you need contrast? And that's particularly relevant given the current contrast shortage. What's the slice thickness? And do we need ECG gating? And if we do, how are we going to go about it? So I'll sort of cover each of these topics as it relates to specific cardiac CT protocols. But before I go there, I just want to make a comment about the importance of windowing. This is sort of like radiology 101, but I think in general cardiology training, it maybe often doesn't come up. But when you're looking at studies, when you're presenting studies, you know, you should always be, of course, making sure that you have the appropriate window level and the appropriate window width. So how are these defined? So the window level is the midpoint of the range of CT numbers that an image contains. So when this number is really low, the CT image will be brighter, okay? Whereas the window width is the range of CT numbers that are in that image. So here are some examples with different preset windows. If we're looking at a CT angiogram or a CT head presetting or lung or bone, you can see as the window level is lower, the image is brighter. And the window width really informs the shades of gray. And that's important. And we really want to adjust that window width so that we can distinguish between our structures of interest and have the right number of shades of gray, if you will, in our image. So a narrow window is usually preferred when we're assessing areas of similar attenuation, such as soft tissue structures, whereas we'll use a wide window if there's very differences in attenuation values of the structures of interest, say from the lung or from the bones. Okay, that's just a little bit of background because I think it's just a kind of fundamental concept that sometimes doesn't come up in internal medicine or general cardiology training. Okay, so first, the basic building blocks. We start with the field of view. What is the range and what is the structure of interest? And usually the technologist will perform a localizer or a scout image and then decide what the range of the study should be. And within cardiac CT, the general options we have are to image from the carina through the heart. So that would be like a pulmonary vein protocol or coronary CT angiogram. From the thoracic inlet to the diaphragm, as we do in a lot of our gated chest studies to look at the thoracic aorta. Or from the thoracic inlet to the ischial tuberosities, which is a typical field of view, of course, for our TAVI protocols and our endovascular stent planning. Okay, next, which I touched upon, is contrast. Do you need it? And if you do, what is the timing of that? So our options are, you can have a non-contrast study, and that's often perfectly fine for assessing aortic caliber or for doing reoperative planning for repeat cardiac surgery. You can have left-sided contrast, and that is timed to optimize the opacification of the aorta. Or you can have right-sided contrast, in this case, like in a PE study, where the contrast is really optimized for the pulmonary artery. The reason this is important, and I think this example shows it, in some PE studies, if the contrast is entirely on the right side of the heart, you could potentially miss significant aortic pathology. So that's something that comes up when I'm on staff in the CCU. A patient is in a community hospital and they have a PE study and we're suspecting acute aortic syndrome, but it may be a suboptimal image if the contrast timing was not appropriate. And then in addition, you know, we can have delayed acquisition, often good for seeing the venous structures. So as an example, in our cardiac device lead extraction protocol, we perform a delayed acquisition of the contrast. And in endovascular stent protocols, we'll usually perform a non-contrast study, an arterial phase, and a delayed phase. And the reason for that delayed phase primarily is to look for endovascular leaks that may not be apparent on the initial arterial phase. Okay, so how do we go about it? Well, there's different approaches, but this is bolus tracking, where you put a region of interest, in this case, in the descending thoracic aorta. So we're going to have left-sided contrast timing, and you track it. And once you reach a pre-specified trigger threshold, in this study of 145 Hounsfield units, you tell the study to the CT to take off. Now, what you'll notice on this image is there's actually a flap here. So there's an ascending aortic dissection. And I highlight this because, dedicated cardiac CT technologists are fantastic and extremely helpful, and we certainly need more of them. And a good cardiac CT technologist, for example, if there is a dissection, let's say it's in the descending aorta, that attenuation may not increase rapidly because the false lumen isn't being opacified, and the tech needs to be on top of that to then manually trigger the study. And this is an example of what I just touched upon, is when you really don't have any contrast on the left side of the heart. Here you can see that the ascending thoracic aorta is dilated, and the patient had acute chest pain, and this was a echocardiogram performed by the cardiology fellow at the bedside. And what you can see here is this dissection flap in the ascending thoracic aorta. Okay, so the next thing we think about when we're deciding our CT protocol is what's the slice thickness. And here are some examples. So for a TAVI protocol, we usually do reconstructions at 1 millimeter slice thickness. For cardiac CT angiography, you can go we typically go even smaller. For a pulmonary vein protocol, we typically do reconstructions at 1.5 millimeters of slice thickness, whereas a gated chest, we may do 2 millimeters or 3 millimeter slice thickness. And I think the point to remember is that the lower your slice thickness, it will improve your spatial resolution, but does increase your noise. So the image becomes grainier. So here's the same image, and you can see the difference in terms of how the spatial resolution looks and the plasticity or the graininess of the image as you go from 1 millimeter to 5 millimeters to 10 millimeters of slice thickness. Okay, and then the hallmark of cardiac CT is really ECG gating. And this is essential due to motion of the heart and the aortic root during the cardiac cycle. And there's different ways that we can do this, and I'll just touch briefly upon that. And I should mention the next few slides are courtesy of our CT physicist, Frank Dong. So what we prefer, for example, in coronary CTAs is axial sequential imaging with prospective ECG gating. Okay, this is the step and shoot approach, if you will, where you acquire some images, the gantry moves, you acquire some images, the gantry moves. Now, the reason we prefer this is because it lowers the radiation dose. However, it's important to emphasize that it may not be possible in patients with arrhythmia, or it could be limited if there's a lot of patient motion. Another type of ECG gating is helical or spiral imaging with retrospective ECG gating. Okay, so here we're doing spiral imaging, and we're acquiring data as the patient is moving through the scanner. So the advantage here is you can reconstruct different phases of the cardiac cycle. So this is what we're talking about when we talk about 4D CT. We're talking about retrospectively ECG gated studies. The disadvantage, of course, is that it comes with the cost of a higher radiation dose. The other approach that I'll mention briefly is with Siemens scanners, prospectively ECG triggered high-pitch spiral imaging. So this is a technique that you can employ when you have two sources and two detectors, so that you can decide when you're going to ECG trigger. And because you have two detectors, you can do a high-pitch acquisition, so you can move the patient quickly through the scan and acquire the images with spiral imaging. So this is something we use a lot in various protocols, and especially is good for the improved temporal resolution, which with the 4 scanner can get as good as 75 milliseconds. Okay, so now that we sort of know what the basic building blocks are, what we think about when we're thinking about a cardiac CT, how do we pick a protocol, and how does that inform what we're going to do for the patient? So we'll start with our gated CT of the chest, where the field of view is from the thoracic inlet to the level of the diaphragm. Again, you can do this with or without contrast. If you give contrast, this is typically an arterial phase with a slice thickness of 2 or 3 millimeters. And we're typically doing this with as prospectively ECG gated or this high pitch prospectively ECG triggered spiral imaging that I mentioned. So what are the questions we want to answer? So we want to generally know about the size of the thoracic aorta. We want to about the present and extent of aortic atherosclerosis. And for patients undergoing repeat cardiac surgery, we want to know the relationship of the cardiac and vascular structures to the sternum. So I would note that there are sort of characteristic patterns of thoracic aortic calcification. So here you see this patchy calcification that's typical of atherosclerosis, whereas in a patient who has a history of aortitis, there tends to be more confluent calcification. And where we really see the most dramatic calcification of the thoracic aorta is patients who have radiation-associated cardiac disease. Here you can see the circumferential severe calcification. The other thing to keep in mind when you're doing studies with different fields of view is what is the typical distribution of thoracic aortic calcium. For example, calcium tends to be more commonly observed in the aortic arch and proximal descending thoracic aorta. So if that is a clinical question, of course, if you're doing a coronary calcium score or pulmonary vein CT with a more limited field of view, you may not image the aortic arch and isthmus. In terms of the value of contrast, it really helps to determine the extent of the non-calcified atheroma. But again, I think given the shortage we've had with contrast, I think we always should, but especially now, is reassess whether the contrast is really needed to answer the clinical question. And so here's an example of a porcelain aorta. This is a patient with radiation-associated cardiovascular disease. You can see this severe circumferential calcification of the ascending aorta, and also the extent of the calcium along the proximal pulmonary artery, which I really have only seen in patients who have radiation heart disease. So this is very important to know if you're planning cardiac surgery. I think historically the porcelain aorta has been defined sort of practically as severe calcification that precludes safe aortic cross-clamping or cannulation. And I think, like a lot of things that have come up of the TAVR studies, there's been a more standardized definition, but really says the same thing. We think of a porcelain aorta when there's heavy circumferential calcification or severe atheromatous plaque, such that cross-clamping is not feasible. And this was one of the main reasons for inoperability in the initial partner study. So a question that comes up is, do all patients need a cardiac CT before heart surgery? What I would say is it depends on the indication. If it's a patient who's going for CABG, the incidence of finding severe aortic calcification that's going to change your operative plan is quite low. The other thing I would note is often on the angiogram itself, you can see if there's severe calcification on the fluoroscopic images. So that's generally low yield. However, in patients with aortic stenosis, and more, I think patients with aortic stenosis are getting TAVI protocol CTs because a lot of the decision in TAVI versus SAVI is based upon the anatomic assessment. But in a lot of those patients, you do find significant ascending aortic calcification, which may change your approach, and the radiation heart disease concerns I've already touched upon. But the other point that's important is that essentially all patients, at least for us, all patients who are undergoing repeat cardiac surgery get a cardiac CT. And this is because after the initial surgery, there may be adhesions and there may be important structures that are either adherent or in close proximity to the sternum, such as the ascending aorta, such as surgical grafts. So it's really good to know this to be able to plan appropriately. And in a substantial percentage of the patients, it does actually change your approach. Okay, so that's some of the uses of a gated CT of the thoracic aorta. I'm now going to transition to talking about pulmonary vein CT, and I know we're going to later in the lecture series here touch upon imaging patients with atrial fibrillation. But the pulmonary vein CT, so again, it's the field of view is the carina through the heart. We do arterial phase imaging, typically do reconstructions at 1.5 millimeters. And there's different ways to approach this, but we generally will do prospective ECG gating that's timed at end systole when the atria are at their biggest. Why do we do this? So it's helpful to fuse CT images with the electroanatomic map. After ablations, it's good to look for pulmonary vein stenosis. We can also look for left atrial appendage thrombus, and more planned percutaneous interventions of the left atrial appendage. So here's an example. This is a coronal projection of a patient who has mild left superior pulmonary vein stenosis following a PVI. And here's a multiplanar reconstruction of a patient who has a more significant left superior pulmonary vein stenosis, which we can reconstruct and give measurements to. And these patients, if they're asymptomatic, the general approach of our EP group can include doing VQ scanning to see if there's any perfusion defect. In this patient, thankfully, there was not. The other thing about pulmonary vein CT is the assessment for left atrial appendage thrombus. So here is a patient who has decreased attenuation of the left atrial appendage. You can see that here on arterial phase imaging. And again, I mentioned the importance of the cardiac CT technologist. Our technologists, when they see this, will then do a delayed phase. And what you will often find is that on delayed imaging, there's homogeneous opacification of the left atrial appendage. So this would be compatible with stasis of blood flow and not a left atrial thrombus. So what are the data in terms of using pulmonary vein CT to exclude left atrial appendage thrombus? Well, there are a couple of meta-analyses. This one is from circ imaging a few years back. And I think the takeaway is that, especially when you're performing this delayed imaging, pulmonary vein CT does perform with a very high negative predictive value. Okay, maybe as much as 100%. I don't think anything in life is 100%, but I think it performs very well at excluding a left atrial appendage thrombus. However, this hasn't been mentioned in either the ESC or the ACC atrial fibrillation guidelines. So in general, we would still probably reserve this for patients who have a contraindication to TE. Or what I think we do more and more is the patient who's going for percutaneous left atrial appendage occlusion, we can do the CT ahead of time, make sure there's no thrombus, and then follow, obviously intraprocedural echo and echo after the procedure, but just to spare them one additional TE. And the other thing with getting the pre-procedural pulmonary vein CT is that can help to size the device that you may be considering, be it Watchman or Amplatzer, for left atrial appendage exclusion. And this is I think there's now a lot of studies, single center studies along these lines. This is one from our group that just emphasize the value of pulmonary vein CT in guiding the Watchman device. And there's always incidental findings that end up being particularly important. So what you can see here is this very prominent azygous vein. And so what you see here is azygous continuation of the IVC with absence of the hepatic IVC. So this was excuse me one second. So this was a patient who was planning for PVI and had this CT scan. And what you can see is, obviously, if you're trying to go through the common femoral vein, it's not going to work. So this patient actually had their ablation done via the subclavian vein. Okay, so what about endocarditis? So this is something we're doing more and more, and I think is helpful in certain clinical contexts. We do this initially as a 4D CTA of the heart. So the field of view is going to be the carina through the heart. And then we follow that with a gated CTA of the chest. So our initial phase is going to be kind of an arterial acquisition, and then more of a delayed phase. We usually will reconstruct the heart at 1 millimeters and the chest at 2 or 3 millimeters. And as I noted, we're doing the retrospective ECG gating of the heart, and then we'll usually either do a actual sequential ECG gating or a flash, if you will, acquisition of the chest. So what is the role of CTA in endocarditis? So it helps to diagnose and delineate the extent of invasion. And I'll touch upon that in the next slide, because I think it may be something that's not as familiar to a lot of cardiology fellows. The CTA in patients who've had prior surgery certainly helps us in the planning for reoperation. Of course, we can use CTA to assess the coronary arteries, and endocarditis is a systemic disease. So we're looking for emboli and phenomenon elsewhere. So what do we mean by invasive disease in endocarditis? So this is when the tissue disintegration involves the valve annulus and the infection invades extracellular areas. And like any infection, this sort of progresses along a standard line.
I think that's a lie, personally.
What's that?
I think it's a lie.
Is there a question? Sorry.
No, that's not true.
Okay. So like any infection, you can progress from cellulitis to abscess, to then forming an abscess cavity, and finally a pseudoaneurysm.
No, a pseudoaneurysm.
Okay. So I guess the question is, how common is invasive disease? So this is from our center, over 1,200 or so patients who went for surgery. So there's obviously some referral bias because you went to the operating room. But what you can see is in right-sided endocarditis, it's very uncommon for us to—
What does referral bias
invasive
mean?
Disease. I'm sorry, if you could please keep your microphones muted. I'd appreciate that. Whereas conversely, in aortic valve, we tend to find invasive disease in about 2/3 of patients. And similarly in patients who have aortic and mitral valve endocarditis. The other point to make is that invasive disease, such as aortic root abscess or pseudoaneurysm, is much more common in prosthetic valve endocarditis versus native valve. So you can see in our patient population of patients operated, invasive disease was actually quite common, 82% of the cohort with prosthetic valve endocarditis. So there's been numerous single center studies looking at the diagnostic accuracy of CTA compared to echocardiography or compared to surgical findings. And I've sort of summarized some of this literature just to give us a sense of how well CTA performs as it relates to detecting vegetations or invasive disease, or in particular patients with prosthetic valves. So if I combine all these studies in the literature, what you can see is the detection of vegetations is not great. Sensitivity of 84% or so versus a specificity of 89%. In the next 10 minutes or so, kind of conclude, because I do want to leave some time to address any questions that come up in the chat as well. Where we left off is I was just highlighting the often complementary value of CT and transesophageal echo in patients with endocarditis. This is a paper from our group a couple years ago that also highlighted that. So just some examples. So this is a patient who has a bioprosthetic aortic valve. You can see these really abnormally thickened leaflets. There are these hypodensities prolapsing in the LVOT compatible with vegetations. And you see this heterogeneous attenuation anterior to the bioprosthetic valve compatible with the root abscess. And part of the reason I show this case is to remind me to mention that, remember, in transesophageal echo, we're sitting behind the left atrium. So if there's a mechanical valve, for example, we may be shielded from seeing the anterior aortic root if that pathology is involved. So that's often better appreciated on a surface echocardiogram if you have reasonable acoustic windows, or of course on a CT scan. This is another example of a patient who has a very large contrast-filled outpouching compatible with a pseudoaneurysm inferior to the left anterior descending coronary artery. Here's a similar case in the sense that you see this contrast-filled outpouching consistent with an aortic root pseudoaneurysm and a patient with a bioprosthetic aortic valve. And here, though, you do see, in addition, an abscess along the aortic mitral intervalvular fibrosa. And now this is a case, this was a younger patient, as I recall, so we did do ECG dose modulation. So we sort of decide that on a case-by-case basis on whether to ECG dose modulate. That's where, the images get really grainy because we take the tube of current very low to reduce the radiation exposure. So there may be situations in a bioprosthetic valve dysfunction case where you really want to have high quality images of all phases of the cardiac cycle, but that may not be necessary for a lot or at least some of patients. Now, the infection in prosthetic aortic valves often spreads along the sewing ring. So here's a near circumferential pseudoaneurysm of the aortic root. And the surgeons tell me that often they can just really pluck these valves out, and it's sort of amazing how loosely tied down they are. And here's a patient where the CTA also demonstrated a fistula from the left ventricular outflow tract here into the right atrium and the right ventricle, which is also very nicely delineated on this transesophageal echo. Now, an advantage of CT is the field of view. So here's a patient who has a contained rupture at the site of a prior aortic cannulation. And in RCC, I probably see this a couple times a year, where it's a patient who may have Staph aureus bacteremia, and at the prior aortic cannulation site, that can be a nidus for infection, which they can rupture. But this is sort of in the mid-ascending aorta, and as you get up and more superiorly, that's a difficult place to image with echocardiography. And here are the operative images of that. And then, as I touched upon, of course, we get the ancillary data related to the assessment of the coronaries in these patients. And here's one of the cases I showed before, where you can see the pseudoaneurysm inferior to the LAD there. And it's important to remember that endocarditis is a systemic disease. So in collaboration with our infectious disease consultants, we'll often image the head, of course, the abdomen and pelvis to look for metastatic embolic events. So here's a splenic infarct and a renal infarct. Okay, so I'm going to go over this a little bit quickly because, again, I think probably TAVI CTA is a lecture in and of itself. But the general concept is we're going to do oftentimes a 4D CT of the heart, of the aortic valve in particular, for that assessment. And then we'll follow that with an image of the chest, abdomen, and pelvis. And the main questions that come up is we're interested in the aortic valve, the annulus area, the coronary height, the aortic root, and sinotubular junction geometry, as well as the iliofemoral atherosclerosis and caliber. So here's just some examples of where on CT you can really appreciate the extent of the annular calcification. And there are some grading systems to kind of further qualify that. And then, of course, we measure the height of the coronary arteries from the annulus. And we want to know the aortic root, how capacious these sinuses are to accommodate a valve in valve. So we'll often embed the geometry of the valve we want to implant. And then, for example, we can measure the distance from that virtual transcatheter heart valve to the coronary artery to try and assess whether there's any risk for coronary obstruction. And then, of course, coronary CTA, 4D CTA of the valve is incredibly useful for looking for valve thrombosis or hypoattenuating leaflet thickening. And here's an example of a thrombosis of a direct flow valve. And this is kind of what you see, this sort of meniscus crescentic hypoattenuation that extends from the base of the leaflet all the way up. And again, it's for the imaging fellows, it's important that you have your multiplanar reconstruction aligned through the center of the leaflet to appreciate that. So more and more, I think, CTA has a growing role in structural intervention. So a lot of the mitral valve cases, we're obtaining CTA. Often these patients don't actually need the abdomen and pelvis. But similarly, we're able to plan and embed the geometry of the transcatheter valve we want to implant to see whether there's any chance of obstructing the outflow tract in particular by measuring the neo left ventricular outflow tract with the planned bioprosthesis implanted. And then finally, CTA can be quite helpful in looking at right-sided structures as well. Of course, we'll contrast the timing. The timing of the contrast will be different in those cases. So it's helpful for the pulmonary transcatheter valve interventions for making those measurements. And if there's other, I guess, less common kind of pathology, this is a patient of mine who developed refractory right heart failure after placement of a permanent pacing wire. And I think what you can see nicely here on this 4D CTA is that this pacing wire was actually impinging upon the septal leaflet of the tricuspid valve and resulting in very severe tricuspid regurgitation. Here's a patient of mine, just as another example, who has carcinoid disease and had bioprosthetic tricuspid valve replacement as well as pulmonic valves, and developed increasing gradients across that tricuspid valve bioprosthesis. And on this reconstruction, you can see this hypoattenuating leaflet thickening and this restricted leaflet motion of that tricuspid valve. And on this, appreciated well on this RV inflow reconstruction, again, where you see this hypoattenuating leaflet thickening. The pulmonary valve looked okay. This patient had bioprosthetic tricuspid and pulmonic valve replacements for their carcinoid disease. And then I subsequently treated the patient with Coumadin, and then on repeat imaging, you can see that the leaflet thickening has improved, but not resolved. And for that reason, I've kept the patient on anticoagulation. And this shows it nicely as well, that it's better, but there still is some leaflet thickening here at the base. Okay, so I think I'll stop there and just summarize by saying that, you know, the kind of pillars of building a CT protocol is just think about, relative to the question you want to answer, what's the field of view I need? Do I need contrast? Where do I need the contrast? What level of slice thickness do I need? Am I interested in something like the coronary arteries, where I need a very, very small slice thickness at the expense of having increased noise? Or am I looking at a structure like the thoracic aorta, where that's less important? And then, of course, ECG gating, how you're going to go about it. And in general, for the gated CTAs of the chest, we're looking at pathology related to the thoracic aorta or planning for repeat intervention. We do the pulmonary vein CTs to look for pulmonary vein stenosis or left atrial thrombus, and also for planning percutaneous exclusion of the left atrial appendage. And I think more and more, there's a complementary role of cardiac CT in patients with infective endocarditis, especially in the setting of repeat cardiac surgery. And then in our TAVI protocol, we're looking primarily at the aortic valve, the annulus, and iliofemoral access. Excellent. So I'll stop there, and I'm happy to take questions or on the chat here for a few minutes.
Thank you, Dr. Grammer, for such a very interesting talk. I think that was, at least speaking for myself, that was not something that I really thought of, and it was a great introductory lecture, at least for me. We do have two questions at the moment, one from Sapide, who's also part of the IOACC chapter. So she said, very interesting info about indications for CT before surgery. How recent does the scan need to be before surgery? For example, would the findings on a scan from a few months prior still be acceptable?
Right, I think that's a good question. And to your point, I think I don't know how familiar a lot of the sort of acquisitions I talked about and cases, but I think it's going to be more and more relevant to the practice of general cardiology. And so I think this is a nice forum to really bring, I think we need to, clearly incorporate more and more cardiac CT into our training programs, even for people who aren't going to be cardiovascular imagers. And that's related to coronary CT angiography and coronary calcium scanning, of course, but also I think these other aspects of cardiology, specifically as it relates to structural electrophysiology and surgical interventions. To answer the question, it's a good question, because I think, what will happen is the patient comes to the emergency department, they have a PECT scan because they're short of breath, and then they get admitted, they're found to have an NSTEMI, they have multivessel disease or have AS. We'll usually look at those CTs and say, is this enough to kind of answer the question? And again, we just want to be good stewards of the profession and not repeat studies unnecessarily. In terms of the warranty period, if you will, I think you could probably get a bunch of different opinions from various clinicians. I think certainly within 12 months it's fine, and especially if there hasn't been any interval change in the patient. But if it's been 5 years prior, I would probably repeat the scan.
Thank you. And then we have another question from the chat from Jeff Lee. So although retrospective studies can be performed in patients with endocarditis, is there a heart rate cutoff where you feel that it won't be diagnostic?
Yeah, so that's also a good question. So, and I think again, I don't think certainly endocarditis, a CT with contrast in an endocarditis patient isn't for everyone. I mean, if there's some renal insufficiency and there's some concern there, I think just doing a non-con and looking at the thoracic aorta and looking at the structures in relation to the sternum is perfectly fine. I would say with the heart rate issue, that if we're doing a retrospectively ECG gated study, that's less of an issue, especially on a dual source scanner like a Siemens Flash or a Force scanner. So the heart rate control really comes up more when we're looking at prospectively ECG gated studies. But the other important point here is, and the importance of having clinicians involved in the protocoling and the interpretation of these studies is how you pre-treat the patients. If a patient has bioprosthetic aortic stenosis or severe aortic regurgitation, this is not a patient you want to be giving a lot of intravenous metoprolol or oral metoprolol to try and drive the heart rate down to do the study. So that could certainly get you in trouble. So we typically don't, even in the assessment of the coronaries, we really aren't, it's usually these are younger patient population or, and the ones where we're using the CTA for the preoperative planning. Oftentimes we're not even giving these patients nitro, but I still think you see the proximal and mid coronaries quite well. And of course you get the assessment of whether there's any underlying coronary atherosclerosis.
Awesome, thank you. And then it doesn't look like there are any other questions in the chat for now. So I did have a question. I may have missed this if you had discussed it, so I apologize in advance. But for the ECG gating studies, if the patient is having a lot of ectopy or if they're an AFib, does that at all affect the quality of the CT, or does it depend on what you're looking for?
Right. So that's also a good question. I mean, really to do a prospectively ECG gated study, it's best if the patient is in sinus rhythm and not having a lot of ventricular ectopy or atrial arrhythmia. What I would say is there's different approaches that have been described. For example, in the patient in AFib, you could trigger off the QRS and do an in-systolic reconstruction because that systolic interval seems to be more constant than trying to image in mid-diastole. But yeah, that certainly is an issue. You can do retrospectively ECG gated studies. And even now, if you're doing a retrospectively ECG gated studies, I think with really aggressive dose modulation, you can bring the dose down quite a lot. So that can be an approach to try as well in someone who's having a lot of either a higher heart rate or having a lot of ventricular ectopy. And again, I think, as I mentioned a couple times, just knowing your cardiac CT technologist really well, because oftentimes they can, after the fact, do some ECG editing to clean up that image if there is some noise or artifact.
Awesome, thank you. Dr. Ashwath, do you have any questions or anything to add?
I think she needs to be unmuted.
I'm trying to sort out now. I think I put so many securities on here and for good reason. But
hello. Yeah, can you guys hear me now?
yeah, sorry about that.
Yeah, no worries. I apologize very much, Dr. Creamer, and to the audience for the inconvenience we had with the hackers today. That was unfortunate. Hopefully we have resolved all the issues. Thank you very much also for not just doing the talk, but for accommodating all these inconveniences and being patient with us. Appreciate very much, Dr. Creamer. I'll move on to introducing our next speaker for the day, Dr. Matthew Budoff. Dr. Matthew J. Budoff is a professor of medicine at the David Geffen School of Medicine at UCLA and the Endo Chair of Preventive Cardiology at Harbor UCLA Medical Center. He's a graduate of University of California at Riverside and graduated a member of the Alpha Omega Alpha from George Washington University. He completed his training in internal medicine cardiology fellowship at Harvard, UCLA. He's on the editorial boards of several cardiology journals, including Clinical Cardiology, Journal of Invasive Cardiology, JACC, Cardiac Imaging, and Cardiovascular Diabetology. Dr. Budoff has served on a number of association committees, including a secretary and executive committee member for LA Biomed, current board member for the American College of Cardiology, and member of the ACC Annual Scientific Sessions Program Committee. He also serves on the executive committee of the ACC Center of Excellence on Cardiovascular Risk Reduction. He has authored or co-authored more than 50 books and book chapters and more than 2,000 articles and abstracts. He has received numerous research grants from the NIH and has been invited to lecture at cardiology conferences all around the world. In addition to his 2015 appointment as the Endo Chair of Preventive Cardiology at Harvard UCLA, he has been recognized for his work by the SCCT, from which he received the Gold Medal Award and recently designated as the Master of the SCCT. He also has been named as the most influential scientific researchers in 2018 and 2019, and was awarded the Albert Nelson Marquis Lifetime Achievement Award in 2018. His research is devoted to advancing procedures that can help doctors identify patients early that are at high risk for cardiac events and progression of atherosclerosis. This early detection can lead to patients being placed on the correct therapeutic path to prevent a heart attack. His research also focuses on thoracic aortic calcification, aortic valve calcification, microannular calcification, pericardial fat, liver fat, myocardial scar, and bone mineral density. We understand how busy he is and appreciate him giving his time to the Iowa PIT lectures. And he's going to be talking to us today about cardiac CT and calcium scoring. Thank you very much, Dr. Budoff, for doing this.
It's a pleasure to be here. Let me share my screen and take you through this talk. So I think a little bit different than what we heard previously as far as the utility and some of the studies. And this has obviously been a well-validated area for a long time. We've been doing coronary calcium research since the first papers came out in 1989 from Dr. Agatston. So let me take you through this. These are my conflicts of interest. So currently, this is how we do our preventive screening. We have a series of questions that we ask about diabetes and smoking and cholesterol, and we use population-based risk factors to try to assess the individual. And that doesn't work very well. As you know, some people are more susceptible to things like cholesterol or blood pressure, and others are not. People get dilated cardiomyopathy from poorly controlled hypertension in their 30s, and other people live an entire lifetime with poorly controlled high blood pressure and have no end organ damage. So trying to use population-based assessment just doesn't work. And when you try to evaluate that, this is from Jamal Rana up in Northern California, did a study of over 300,000 patients and looked at the estimated risk in orange. That's what the risk calculator said the event rate would be. And in blue is what actually happened in the population. So this was a prospective evaluation, a 5-year follow-up. But you can see, really, unfortunately, gross overestimation by the risk equations. So the population-based assessments overestimate risk in most people dramatically. And the problem with that is lack of compliance, is poor distribution of therapies, and certainly terrible targeting when you're overestimating risk in 75% of patients. Coronary calcium is a personalized evaluation. It looks at the individual's plaque burden, and it's a lifetime accumulation of atherosclerosis. Now, calcified plaque is not all of atherosclerosis. It is a portion of the whole. So you can see here, 20% of calcified plaque is 25% of plaque is calcified and 80% is non-calcified. So you can see a wide distribution of of plaque and atherosclerosis in any given lesion. But when you look at the entire coronary bed, about 20% is calcified. So think about the iceberg, and while it's only showing you what's above the surface of the water, when the Titanic was going downstream and saw across the ocean and saw a big iceberg, it didn't send divers below the surface to wonder if there's anything there that could rip the hull. It knew what to expect. And the same should be true with coronary calcium. If you see a lot of calcified plaque, you should expect in that patient, not in that lesion, but in that patient, that they have a lot more fibrotic and lipid-rich plaque and vulnerable plaque as well. So calcified plaque is a good marker of total atheroma burden. Now, we know that it's only atherosclerotic. There is no coronary calcium in the normal vessel wall. So it is purely atherosclerotic. This is from an ACC statement, but it obviously has great independent and incremental predictors for events, and I'll show you some of that data. But understand that when we talk about coronary calcium, we're talking about intimal atherosclerotic disease. Now, there's been a number of studies. This was one of the first population-based studies. This was done in Long Island, looking at the patients. Looking at the patients in that population, you can see that event rate, if patients had a score of 0 over the next 5-year follow-up, this was 5,000 patients followed up for 5 years. You can see that almost no events occurred. So a calcium score of 0, what we call the power of 0, implies a very, very low cardiovascular risk. As the score goes up, the annual event rate goes up, and you tend to cross a high risk state, 2% per year, 20% 10-year risk with a score above 100. But as the score continues to go up, the risk continues to go up. So it's a linear relationship. The more atherosclerosis you have, the more cardiovascular events you will have. This is something that's been known since the Middle Ages. So when we think about the relative risks, this study showed us that if you had coronary calcium above 100 as compared to those with lower scores, you were 10 times more likely to have a coronary event. And if you think of just hard cardiovascular events like myocardial infarction and sudden cardiac death, you are also 10 times more likely to suffer an event. So a relative risk of 10-fold was considered quite high at the time, and a lot of people didn't believe that this data was as robust as it was, because most hazard ratios and relative risks are in the order of 1.7, 2.0. This is 10-fold increased risk, or 1,000% increased cardiovascular risk. I then published data on 25,000 asymptomatic patients, just looking at all-cause mortality. And again, at the top, you can see a score of 0. That's a very, very low cardiovascular risk, a good survival over 12 years, and a score above 100 similarly showed a 10-fold increased risk. So again, we started to see reproducible event predictions that were in an order of 10 times better than other risk markers. This was the multi-ethnic study of atherosclerosis, or the Mesa study, and this again showed a 10-fold increased risk when you had a calcium score above 100. So very consistent data from population-based studies and large observational studies that show that if you have elevated coronary calcium, you have a very markedly increased risk of non-fatal MI and cardiac death, ASCVD in general. And the higher the calcium score, the higher the risk. You can see calcium scores. It's just a volume of calcification. If you're not familiar with it, it just literally quantifies how much calcified plaque is in the coronary arteries using a non-contrast CT. So much simpler algorithms than what we just heard from the structural world with CT. A very simple test to acquire. It takes less than a minute to acquire the data. And patients, again, no IV, no needles, no injections, no contrast. It's just a simple hold your breath for about 10 seconds. We take some pictures and you're done. And you can see a calcium score above 300 imparted a 14-fold increased cardiovascular risk. So a markedly increased risk with higher calcium scores. I then did true 10-year outcomes on the Mesa study, the multi-ethnic study of atherosclerosis. This was a trial looking at different ethnic and racial groups. And you can see here very nicely the similar results when you look at any of the 4 ethnic groups. If we break this down and look at a specific ethnic group, just to blow this up a little bit, you can see a very light gray bar at the bottom. That represents a score of 0. And even over 12-year follow-up, they remain below a 7.5% 10-year risk. So well below a 1% annual risk with a score of 0. As the score went up, the risk went up proportionally. And we always see the stepwise increase. The more atherosclerosis you have, the more coronary calcium you have, the higher the cardiovascular event rates. And you can see that a score of 100 in dark gray, quite high event rates over the next 10 years. And in black, a score above 300, even higher. Now, some people have said, well, this is really only robust for heart disease and not for stroke. But if you look at this 23,000 person follow-up from Walter Reed, you can see that the risk prediction scores above 400 in red now and 100 in green. Again, a stepwise increase for each of the cardiovascular events with a p-value less than 0.0001 for each of the different individual components. Myocardial infarction. You can see a nice stratification of risk. Stroke, a very nice stratification for risk, but even just major adverse cardiovascular events or mortality, a very nice stratification of risk. So this plays out very nicely across multiple cohorts. And again, just to reinforce this power of 0, when you look specifically at 7,000 patients with a score of 0 followed for up to 15 years, you see near perfect survival. So a score of 0 imparts a very low cardiovascular risk. And therefore, a very nice way of down stratifying people to say that they are lower risk. Now, how do risk factors compare? This was work done by Mike Blaha and Mike Silverman at Hopkins, looking again at the Mesa trial. But you can see a very nice stratification if you look at yellow, calcium score of 0, whether they have 0 risk factors, 1, 2, or even greater than or equal to 3 cardiac risk factors, their event rates are remarkably low. So risk factors didn't add much to coronary calcium. But look at it the other way. Look at the greater than 3 risk factors going from yellow to gray to green. An increase in calcium score adds incredible value and predictive power. So having a lot of risk factors and no coronary calcium implies a low risk state. Having a little bit of calcium now implies an intermediate risk state, and a score above 100 implies a very high risk state where patients were 10 times more likely to suffer an MI, stroke, or cardiovascular death. When we talk about the power of 0, we talk about de-risking people. In other words, identifying how low their risk could be, and therefore, could we afford to not treat them with a statin? Could we afford to forego lipid therapy or aspirin therapy or other treatments and stick to lifestyle? And this study, again from Mesa, looked at all of the negative risk markers. In other words, what should impart a low risk state. And you can see a low Lp(a) did nothing at all. The dark black line is the overall population risk. Having an Lp(a) less than 25th percentile afforded no cardiovascular protection at all. Actually, those patients were slightly above the overall risk. If you look at a high HDL or ApoA1 above the 75th percentile, again, no cardio protection. That line is above the general population. Well, what's on the downside? What's lower risk than the general population in this study? Well, in HSCRP in red, if you were below the 25th percentile, you were at a lower risk of having a cardiovascular event, but the benefit was modest. Interestingly, a galactin-3, a biomarker we don't use in clinical practice, actually did better than HSCRP. The absence of carotid plaque was even better, but at the very bottom, really low risk, less than 1% event rate over a decade was a calcium score of 0. We also like to measure populations based on the net reclassification improvement, or the NRI. And the reason is that we want to know how often does it help us in reclassifying people. In other words, if I have a patient who's intermediate risk and I do a HSCRP, how many people is that going to help? And the answer here was 7%. So you would have to do 16 CRPs just to get one person to move to a different risk category. That was either higher risk or lower risk. So not a very high yield. And you can see ABI and brachial flow mediated dilation, which is kind of like endothelial function testing, really useless in population assessment. Family history helped a little bit, 16% of people. Carotid IMT helped a little bit, about 10% of people. But you can see the coronary calcium score reclassified 2/3 of all people tested. So you do 3 tests in intermediate risk, 2 of those patients will be reclassified as either high risk and go on and have an event, or low risk and go on and not have an event. How high is it to be secondary prevention? So we did a study looking at patients who had asymptomatic without coronary disease, who had just a calcium score, and compared them to 5,000 patients with established ASCVD. And what you can see here is that in red are the patients with a prior MI in the trial, and that was their event rate. And in the green are patients with a score of 0. You can see a much different event rate. But look at the people in purple. In purple represents patients who are asymptomatic primary prevention, who had a calcium score above 300. And those patients had a similar ASCVD event rate as those patients who suffered a prior myocardial infarction. So we can say that a score above 300 imparts secondary prevention guidelines and puts you at a high enough risk where you're going to be a patient who qualifies for all of the secondary prevention treatments. You can think of advanced lipid treatments like PCSK9s or bempedoic acid. You can think of Vascepa, icosapent ethyl. Excuse me. Or you can think of other cardiovascular therapies as well. We know that coronary calcium score improves cardiovascular risk assessment above risk factor markers, and it adds value. This was a study that just looked at that calcium scoring helps match intensified risk factor modification to atherosclerotic plaque burden. So kind of intensity of treatment with intensity of risk. And looked at both how the calcium score impacts both the European and American Heart Association guidelines. Well, what about a score of 0 if you find soft plaque? Well, if you do that CT angiogram and it shows non-obstructive disease, like a 30% soft plaque, or if they have a obstruction, a 50% blockage in a major coronary artery. Well, this was work done from a Denmark registry of over 23,000 patients. And they studied long-term follow-ups. And Denmark's a great country for these type of registries because it's a closed healthcare system. And you can see that if patients had no plaque, their event rates were less than 1% per 1% event rates, or less than 8 per 1,000 patients suffered a cardiovascular event. If they had coronary calcium score of 0 and no obstructive disease, so they had a mild, let's say a 30 or 40% blockage in a coronary artery, some visual soft plaque sitting in the coronary artery, that added no incremental value at all. Those patients also had less than an 8 per 1,000 event rate. If you look at patients who had a 50% or more blockage due to soft plaque only, no calcified plaque, those patients were also remarkably low risk. And you can see that they had the same low risk event rates as patients who had a score of 0 with no plaque. So you went from 7 per 1,000 to 8 per 1,000. So 0.7% event rate to 0.8% event rate, obviously not significant increase. Now you start adding calcium and plaque, and that risk goes up significantly. And by the time those patients were scores above 100, whether they just had non-obstructive disease or obstructive disease, They now had a threefold higher event rate when you followed them prospectively over time. What about biomarkers? Well, most biomarkers don't add much value to our risk stratification models. This is from the Framingham study, Framingham Heart. They looked at 10 biomarkers, C-reactive proteins, B-natriuretic peptide, and NT-proBNP, aldosterone and fibrinogen, things like homocysteine, and even urinary albumin to creatinine ratio, something that's been proposed to be a strong predictor of risk by nephrologists looking at urinary albumin, and proteinuria. And you can see absolutely no incremental value of any of these 10 biomarkers. They just did not improve the area under the curve and really added no improvement in overall risk stratification for either death as a long-term endpoint over 20 years or major cardiovascular events. Well, not all biomarkers have not worked. The most prominent biomarker that we have available today that I think has the best data is going to be troponins. This is a trial that was done looking at a high sensitivity troponin. So again, not looking at patients coming into the emergency department with a positive troponin, but looking at people who have a slight troponin leak in their bloodstream with high sensitivity measures. We can measure troponin in most patients at some level, and those patients who had higher levels of troponin, like those patients with in purple, who had both positive coronary calcium and a high troponin level, had a much higher risk than those patients who had a positive coronary calcium in red, who had a low troponin. So troponin added a lot of value. And the lowest risk patients were patients with a score of 0 and a low troponin in light blue. So you can see that incremental value of troponin is probably the best so far that we've discovered in Mesa. If you wanted to add to a coronary calcium scan, you would add to a coronary calcium scan by ordering a high sensitivity troponin. It is either troponin T, or in this case, or often used troponin I, but both of them are done and add incremental value. So here we can see a study done by Dr. Shemesh looking at ungated studies and the ability of predicting cardiovascular risk in an ungated population. And here we can see that if they had a score of 0, they had a low event rate. This was a lung cancer screening trial. But if they had a high coronary calcium score, and these are ordinal scores, so they work a little differently, but just suffice to say that a ordinal score of 7 to 12 would be probably a score well above 100 and maybe even above 300, and they had a 5.3% risk of dying. And those patients with a moderate score, a calcium score, had a 5% risk of dying. And overall, when you did multivariate analysis, those patients with an ordinal score above 4, which means that even just kind of moderate plaque in their coronary seen by a radiologist on incidental findings, afforded a 4.7-fold increased risk of dying over the next 6 years. So looking for coronary calcium on an ungated study is also very important. Now, when we think about reclassification, we talked about how CT could reclassify some patients. This is another population-based study, but when we take intermediate risk patients and we do a coronary calcium score for reclassification, only 14% of patients, about 1 out of 7, are upclassified to go from intermediate to high risk, identifying a patient who then goes on to potentially have an event. But 2/3 of patients are actually found to have a score of 0. In other words, risk factors, like we started with this talk, risk factors overestimate risk prediction. And in this case, we found a score of 0 in 63% of patients. So getting rid of all of that 4-fold overprediction and lowering that down by 2/3 with a calcium score. So most patients who undergo calcium scoring for risk stratification are actually declassified or decreased. Their risk is lower in an intermediate risk population. So don't assume that everybody who gets a calcium score is going to have a high score and therefore needs aggressive treatment. In this study, 2/3 had a 0 score and were told that they don't need further treatment in the short run. And that's true of other studies as well. This is the Rotterdam Heart Study showing 52% of patients are reclassified and 48% of them downclassified. When we look at calcium scoring compared to other biomarkers, like we did in Mesa, this is from the Rotterdam Heart trial, you can see calcium scoring much better at risk prediction than a host of other metrics that we commonly use in practice. So calcium scoring so far is the most robust risk predictor, and high sensitivity troponin is the best incremental add-on that we know of to date. So what's our value of coronary calcium beyond just saying, okay, Mr. Johnson, you're at increased risk, or okay, Mr. Johnson, you're at low risk, is looking at compliance. So I often get a lot of patients in my office who I believe should be on statins and aspirin and antihypertensives and other therapies, and they're a little reluctant to take medication. So I say, okay, let's get a calcium score. And if I'm right and you have a lot of coronary calcium, a lot of plaque in your arteries, then I want you to go on all of these therapies. And if you're right and your arteries are clear and you don't need these therapies, then we won't deal with this for another 5 years, and we'll wait 5 years to retest you. And this was a randomized trial looking at that exact phenomenon, where they took 2,000 patients and put them on either got a scan as part of their initial assessment, or did not get a coronary calcium scan, which is obviously most commonly done, the kind of the standard of care. And when you got a scan and you looked at them over 4 years, we found that all of the biomarkers improved for cardiovascular risk. 4 years later, patients had a lower LDL by almost 30 milligrams per deciliter if they had a positive calcium score. They had a 9-millimeter drop in their blood pressure. They were more likely to exercise, take lipid-lowering therapy, take a blood pressure pill, take an aspirin, and they were more likely to be adherent to existing therapies. So all of these were statistically and clinically relevant findings, because we can improve upon risk delivery and compliance by getting patients a simple picture of their coronary arteries. And it actually lowered cardiovascular costs compared to standard of care. And the reason is so many people had a score of 0 that we ended up doing less downstream procedures in them because they had a score of 0. They didn't need a treadmill or a nuclear test. And they needed less therapies because they didn't need to be on a statin or possibly other therapies. There's also a study that just came out called CoreCal, done by the group up in Salt Lake, looking at recommendations based on the pooled risk equation, or PCE-based recommendations, and comparing that to coronary calcium. Coronary calcium patients were more likely to be reclassified from statin to no statin and from no statin to statin, with a reclassification of 42%. We also saw patients starting a statin more likely, and physicians accepting the recommendation and starting statins in 88% of patients who had a calcium score versus 75% of patients who were just in the standard of care pooled risk equation arm. So doctors were more likely to act on a calcium score than a pooled risk calculation. Statin adherence at 3 months was higher. It was 62%, not very good, but 62% compared to 42% with the pooled risk equation, which is terrible. But it was a net improvement of 20% in patients who are actually taking the statin based on their coronary calcium scan. And at 1 year, statin adherence remained superior. LDL levels were lower. Costs were similar or reduced in coronary calcium subjects. So now a second randomized prospective trial demonstrating reduction in costs by doing a calcium score and improvement in control of things like LDL and cholesterol adherence. So they concluded that coronary calcium guidance may be a more efficient, personalized, cost-effective, and motivating approach to statin initiation and maintenance in primary prevention. And I would say that that's really only part of the answer, because I think you can look similarly at blood pressure and blood pressure control, at smoking cessation, at diet, at weight loss. We've looked at weight loss over 4 years and showed that patients who had a positive coronary calcium score were more likely to maintain a better healthy body weight as well. Well, does knowledge of a calcium score help us deliver care and lower risk? That's the most important thing, is it treatable? And we can't lower a calcium score, but we can accept that a high calcium score is high risk, and high risk patients benefit from being on things like atorvastatin. And that was studied in the St. Francis randomized trial, where we randomized over 1,000 patients to either atorvastatin 20 or a placebo and followed them for cardiovascular events over 4.3 years. And treatments with atorvastatin reduced clinical endpoints by 30% and MI and death by 44%. So there was a nice reduction in cardiovascular events. And events were more significantly reduced in participants with a baseline calcium score above 400. So you can see that patients had a significant event reduction, 42% less events if they had a score above 400 and were initiated on atorvastatin 20 milligrams. Well, I want to revisit the treatment of a score of 0, because this is now in our guidelines, as I'll show you, that a patient with a score of 0 should not be treated with a statin, or at least you can withhold statins for 5 to 10 years. And there's a lot of observational data that says that patients are low risk, but what about actual treatment data? So this is actual treatment data. This is a population of patients where we see a calcium score of 0 and whether or not they were treated with a statin. There are actually 2 lines there. If you look at the red line, that's patients treated with a statin. The blue line are patients not treated with a statin, and you can see the exact same event rates. So we had 5,600 patients not taking a statin, and that's their event rate over 10 years. And you had 3,700 patients on statin therapy for a decade after a score of 0, and that's also their event rate. And those 2 lines are so superimposed that all you see is a red and blue dashed line. So the event reduction was 0%. And the number needed to treat, if you have a score of 0 and you put them on a statin, the number needed to treat for 10 years is infinity. You literally would have to treat an infinite number of people to try to prevent one cardiovascular event. This is actual data from Walter Reed, another closed healthcare system, where we can look at this. We can't do a randomized trial of patients with a score of 0 of statin versus no statin, because the power analysis would say we would need more than an infinite number of people to be in the trial. If you expect a 0% event rate reduction, which is what we saw here, exactly a 0% event reduction with a hazard ratio of 1.00, you afford no benefit to your patient by putting them on a statin. And I can promise you, if you have 3,700 patients on a statin, some of them are getting side effects. So the ACCHA guidelines, which we'll review in a moment, that say if you have a score of 0, you can withhold statin therapy. It's based on excellent long-term observational data. Well, in that same cohort, what about patients who had a score above 100? Did statins help them? And this is the data of scores above 100. And you can see in red the event rates if they were taking a statin, and in blue the event rates if they were not taking a statin. And you can see a 68% 10-year event reduction. This is exactly what we see in clinical trials. At the 5-year mark, there was about a 30% event reduction that continued to widen over a decade. But now you can see the number needed to treat, if you had a calcium score above 100, is 12. You treat 12 patients with a statin if their score is above 100, and you prevent one major cardiovascular event. What about comparing it to like the Jupiter criteria? Jupiter was a C-reactive protein trial where they said if you had a high sensitivity, high value of hsCRP, that you're at increased cardiovascular risk and deserve to be on rosuvastatin 20. So we looked at this exact population and added calcium scores to the mix. And if you break it down by calcium score, if you qualified for the Jupiter trial and deserve to be on rosuvastatin 20, and you actually look at a calcium score of 0, you'd have to treat 549 people to prevent one event. If you take those same population of patients who have intermediate risk and an elevated hsCRP and score above 100, you need to treat only 24 people. So we can make delivery of healthcare 20-fold more efficient by knowing a simple calcium score. And that's why it consistently saves money in the healthcare delivery. If we look at cost effectiveness data, the cost effectiveness of coronary artery calcium is robust due to better and more accurate targeting, in particular to statin and aspirin therapy, as well as promoting more adherence to those therapies. What about CAC progression? Is it bad? Well, this is a study that I did looking at after the second scan, following them for the next 5 years. And what you can see is if they had a no change or a minimal change in their calcium score, a low absolute change in score, less than 15% rise in their value or less than 100-point change, that their event rates were the same as if they had no progression at all. But if you further look at this population and you look at the patients in green, blue, or red, those are event rates of patients whose calcium scores are increasing. So having a high calcium score and it plateauing and not going up actually lowers your risk back to this orange line. And if you have a low calcium score or a high calcium score and it's continuing to rise over time, you get onto one of these other trajectories. You can see that the event rates were 1 out of 3 patients, 1 out of 3 patients in Mesa, an asymptomatic population who had rapid progression ended up having a heart attack, stroke, or death over the next 7 years. So you can be at very high risk if your score is continuing to go up. So I do believe there's some value in repeating the calcium score to reassess risk over time. It's not an annual test, but I think you can reassess. We did it here at 2.5 years, and we're able to discern a much different trajectory and therefore a different risk. What about aspirin therapy? One of the great unanswered questions is aspirin and aspirin treatment. And here you can see that knowing the calcium score can really help with aspirin delivery. If you look at the patients on the left, those patients who have a low score of 0, and the red line represents the number needed to harm, how many patients will have a major bleed. You can see that the number needed to treat is higher than the number needed to harm, meaning you have to treat 2,000 people to prevent a heart attack or stroke. And those same population would be estimated to have 5 major bleeds from that baby aspirin. Even if they're high risk in red, it's about a 2-to-1 harm. You're gonna have twice as many people harmed as benefit from being on aspirin therapy. And that's why most of the trials with aspirin ended up being neutral, because we didn't know if they had atherosclerosis. And if they have no atherosclerosis, putting them on an aspirin tablet can only increase their risk of bleeding. It can't decrease their risk of having a coronary artery event if they're not going to have a coronary artery event. If you look at the far right, those patients with scores above 100, whether or not you're high risk or low risk by pooled risk equation, you benefit by 5 to 8-fold. In other words, you'll prevent 5 heart attacks for every 1 bleed you cause with aspirin therapy, making it one of the most cost-efficient medicines that we know of. It's cost savings by a lot to prevent 5 myocardial infarctions for every 1 bleed that it could cause. So we can see here that if we know the calcium score, we can impart better aspirin treatment. And I advocate aspirin, a low-dose aspirin for all of my patients who have a calcium score above 100, because I know they have atherosclerosis. And the fact that they haven't had that bad day yet, that they haven't had that MI or stroke, is good in my book. I'd rather them not be secondary prevention patients and still be primary prevention patients, but get them on aspirin to prevent that first heart attack, stroke, or cardiovascular death. So when we think about the big picture and how we can use coronary calcium in our practice, it helps us with better risk stratification. It matches risk of events with intensity of therapy, things like statins and aspirin. 50% or more patients will have scores of 0. In other words, these patients will not show benefit, and that's based not only on the Walter Reed study, but many observational trials, what we call the power of 0, and it improves compliance. So where are the guidelines now? So this is calcium scoring in the 2018 guidelines. If you have a patient with a 5 to 20% risk, which is most Americans, 40% of Americans or more are going to be in this 5 to 20% risk category, you can consider a calcium score measurement. If the calcium score is 0 at the bottom left, it's below the threshold for statin therapy, and you consider avoiding or postponing statin therapy. And they literally, the guideline says, the algorithm says that you can withhold statin therapy for 5 to 10 years. If the calcium score is intermediate, they have some subclinical atherosclerosis progression. You want to think, we do a risk estimate and try to figure out if this is a population that would benefit from statins, and also consider repeating CAC in 5 years to reassess their value, their level. And finally, patients with a score above 100, above the threshold for statin benefit, and recommend statin therapy. This is the actual language. You can see if the calcium score is 0, it is reasonable to withhold statin therapy and reassess in 5 to 10 years. If the calcium score is 100 or higher, or in the 75th percentile, so if they're high for their age or gender, it is reasonable to initiate statin therapy. The chest pain guidelines added calcium scoring for risk stratification. So very important to understand that they said that for patients undergoing stress testing, the addition of coronary artery calcium testing can be useful. And it's mostly for risk stratification, but it can also be looking for patients who have a higher underlying atherosclerotic burden. Remember, with a stress test, you get no indication of how much plaque or athero they have. And they say that we can add an outpatient coronary calcium scanning can provide additional information for long-term risk stratification. The new concept that kind of looks at outpatient guideline-directed management of cardiac risk factors. So you get a low-risk patient or a patient who got a stress test, and you add a calcium score to assess their long-term cardiovascular risk and whether they would benefit, again, from things like aspirin, statins, better blood pressure control, etc. And these are kind of a summary of the 2021 chest pain guidelines in terms of atherosclerosis or coronary calcium. They gave calcium scoring a 2A recommendation for adding coronary calcium testing in intermediate risk patients with stable chest pain and no known CAD undergoing a stress test. Remember, half of patients with normal stress myocardial perfusion have at least moderate coronary calcium scores. So you don't want to tell them that they're low risk based on their nuclear, when in fact they may have a lot of subclinical athero. The nuclear will only tell them, good news, you don't need a stent today, or you don't need bypass surgery today. That's the only value of a stress nuclear test, and that's why it's becoming less common in clinical practice and being used less in most algorithms of care, and why the American Society of Nuclear Cardiology literally took their name off the chest pain guidelines, because they couldn't be associated with guidelines that didn't put nuclear in a more prominent role. But it's no longer in a prominent role in our risk stratification algorithms for chest pain. So just think about that. Whether or not they have obstructive or non-obstructive disease, we want to think about guideline-directed medical therapy. So where to use coronary calcium as we finish up here? Intermediate risk patients, ASCVD 5 to 20% risk. If their risk is uncertain, the guidelines gave a class 1 indication to do coronary calcium testing. Family history, another place where you don't know the genetics. We don't know what genetics are transmitted. So if patients have a high risk state, a high bad family history, I get a calcium score to see if that genotype was transmitted by just testing the phenotype. I test the patient to see if they have plaque. And if they have plaque, I'm like, yep, looks like you got that gene from dad, that risk from dad or mom, and now we need to start getting you on appropriate therapy. It's great, as I mentioned earlier, for statin reluctant or intolerant patients. You'd be surprised how often somebody says, oh, I can't take a statin, when you show them that they have a high calcium score, will all of a sudden be willing to try it again and often tolerate it. It becomes a more compelling indication for them. It might help us as we think about a score of 300 being secondary prevention, things like icosapent ethyl or PCSK9 inhibitors. Decisions for aspirin therapy, I think, are robust, and this is built into the 2019 prevention guidelines, is this discussion about decisions for aspirin therapy. So it's not my theory. This is in our prevention guidelines about a potential of using a calcium score to help adjudicate who benefits from aspirin. And of course, it's a great motivator for all good behaviors, including weight reduction, including exercise, and including diet. So how do you incorporate it in your practice? Well, there is this Mesa risk calculator. You can just type in Mesa CAC, coronary artery calcium, or Mesa risk calculator, and you'll get this website, and you can plug in their risk factors and it'll tell you their risk, and then you can add in a calcium score and it'll recalculate their risk, and you can see how much it up titrates or down titrates their therapy, and then base your decision on the results inclusive of a coronary calcium score. What about you places where we want to be careful about coronary calcium? Well, younger age patients is a problem. Generally, if they're under age 40, we don't want to use coronary calcium in our algorithms of care because they might not have developed calcification yet and classical atherosclerosis. They might have another reason why they have early heart disease, and that's not going to be picked up well by a coronary calcium scan. Some exceptions where we know that young people do calcify. Dialysis patients have a lot of coronary calcium, early onset diabetes, the type 2 diabetics who develop diabetes at a very young age, family hyperlipidemia, familial hyperlipidemia, and extreme family history. If everybody in their family died by age 38, I'm not going to tell them they have to wait till age 40 to get a heart scan. I'll do it at a younger age, but it's the exception to the rule and not the rule itself. And do not follow up a high calcium score with an invasive angiogram. Yes, they have a lot of atherosclerosis, but they may not have a lot of stenosis. And even if you did find a stenotic lesion in an asymptomatic patient who got a calcium score, fixing it probably does not lower their event rates. We have very low expectations. I don't know of anybody who has a high expectation that if you take an asymptomatic person and put a stent in, that they're going to have less heart attacks, strokes, or death. All you're going to do is give them a risk of in-stent restenosis. So I always tell my patients the only way you can die of in-stent restenosis is to get that stent implanted when I don't want them to get a stent. So I'll leave you with this discussion or this concept from 5,000 years ago. This is not a new idea, and I'll read the English, not the Chinese, but superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. Think of things like subclinical atherosclerosis, like coronary artery calcium, and inferior doctors treat the full-blown disease. So thank you very much, and I'll be glad to open it up for questions or comments.
Thank you very much, Dr. Bada, for the great lecture. We certainly learned a lot. This is information that we can certainly implement in our current practice and in the future as well. With that, I would like to present the question from the audience here. The question is, how do you visually assess coronary calcium on a non-cardiac CT and categorize them to, for example, less than 100, 100 to 400 versus more than 400? Thank you.
Yeah, it's a great question. And we do what's called the ordinal scoring system. I think you can just quantify calcium. Any radiologist can use the calcium score algorithms that actually get an exact number for you if you want. I mean, you don't need a gated study, a calcium score, to use the software to measure coronary calcium. So I would say the better approach would be to ask the radiologist to quantify calcium. They might not want to do that because it's one extra step and an extra work on their part to take the scan and import it into a workstation that can quantify it. So if you want to just visually quantify it, we use what's called ordinal scoring. Ordinal scoring is you look at each vessel, so left main, LAD, right coronary, and circ, and you say, okay, is there no coronary calcium, score of 0? Is there a little bit? Give it a score of 1. Is there a moderate amount of calcium? Give it a score of 2. Or is there severe calcifications? Give it a score of 3. And then you get 0 to 3 in each of the 4 vessels. So you can have a range of 0 to 12. 4 or higher is probably a calcium score of 100, and 7 or higher is probably an equivalent of score of 300. It's not perfect, but you can kind of get moderate and high risk based on an ordinal scoring. Again, each vessel 0 through 3, and then add up the vessels to get a total of 0 to 12.
Understood. Very, very good. There was another question that just came through. What is the value of a calcium score of 0 in smokers?
Yep. So a calcium score of 0 in smokers is dissuaded a little bit in the guidelines. They say that that's a high risk state that deserves therapy anyway. We really have no evidence of that. The Walter Reed subgroup did subgroups in patients with diabetes, in patients with family history, in patients with smoking, and that same outcome occurred. If they had a score of 0 and were put on a statin, that did not impart benefit, even if they were smokers or diabetic patients. So I still believe that if their score is 0, that their risk is low, regardless of whether they're smoking or have a family history of heart disease. And therefore, we can work on smoking cessation. I'm not saying that they should continue to smoke because they have no coronary calcium, but they certainly, I don't think, would benefit from a statin, at least in the next 5 years. And then you can reassess their risk in 5 years as the guidelines, as the 2018 ACC/HA guidelines recommend, get a repeat scan in 5 years. And if they're developing calcium, you can always institute therapy at that point. Nobody's going to go from a score of 0 to a score of 300 in 5 years. So you don't have to worry about missing anything if it has a score of 0. You have time to treat them with lifestyle changes, like smoking cessation.
Okay, thank you very much. Moving on from that, I also had a question myself. Sorry if I missed it during the lecture, but basically the long-term risk stratification for cardiac events in patients is calcium scoring, is it found to be more superior to other diagnostic modalities, or is it a good modality to even long-term risk stratify patients?
Yeah, so I think, we've looked at the 10-year event rates, and Walter Reed looked at 12-year event rates, and it still holds up very well where the event rates continue to accrue over time. I don't believe in lifetime risk assessment because I believe that we can interact in our patients more than once in a lifetime. Lifetime risk assessment would mean that you only had one point of contact and you have to make a lifetime decision. So I think it's, to be honest, kind of a silly concept. I would advocate that we should see our patients more than once per lifetime and make different decisions as they get older. Some patients develop diabetes, some patients' cholesterol go up after menopause, some patients have hypertension that develops. Their risks change. So get a repeat scan at 5 years if you're not sure of where they are. If their score was 0 and now they have new onset diabetes and you're worried about them, you can get another scan. I'm not saying that we wouldn't be treating their diabetes or their smoking or other risk factors, but we can then institute targeted therapies based on what we see on the calcium score. And so far, there's nothing even close to the risk prediction we get with a calcium score. We've looked at a lot of biomarkers. We've looked at genetics. We've looked at other imaging with MRI, with carotid. We cannot emulate the risk prediction that we get with a simple calcium score with any other test so far. Not to say that there won't be development in the future, but right now we're stuck with what I would consider to be an excellent and easy to deliver mammogram of the heart. That's what my boss called it many years ago. He said, this is the mammogram of the heart, that people are going to get it at a certain age and they're going to know, are they going down that road of like a positive mammogram? Are they going down that road of potentially having a disease, or is it clear? And they can then get retested at some interval to make sure that they still don't have the disease. And that's what you want to do.
Makes sense. Makes sense. Thank you.
There's a good comment real quick before I forget. Somebody mentioned on the ordinal scoring when I mentioned that earlier, that not all the CT scans are done with 120 kilovolts.
Yes.
The voltage has to be 120 and to do a calcium score. So if they do a low dose lung scan, we use less voltage, less wavelength to penetrate the patients to reduce the radiation exposure. So they might use 100 kV or even 80 kV. If you lower the voltage, the calcium gets brighter. So you will overestimate calcium. It won't turn a 0. I probably won't turn a 0 into a positive, or if it does, it would be a trivial amount. But it will make calcium look a lot worse. So just take a quick look. If it's on a lung scan, look at the voltage and maybe just in your own mind down titrate it a little bit. But it's still, if you see a ton of calcium, there's a ton of calcium there. But just be a little more cautious in the interpretation if it doesn't say 120 kV in the upper left corner of the scan.
Okay. And there was another question about value of calcium score follow-up for patients on statin therapy.
Yeah, a big unfortunate misconception based on intravascular ultrasound data. Steve Nissen from Cleveland Clinic published work based on IVUS and said based on IVUS that calcium changes and therefore that we should not use a calcium score, which is really a stretch because I think intravascular ultrasound and coronary artery calcium scanning are different modalities. But nonetheless, the concept that there is a slight shift from soft plaque to calcified plaque with statins is correct. The problem, the reason that it's not a problem with coronary calcium is that if you're on a statin, your calcium progression rates are not very high. They're normal. They stay in the normal range. So if you're still rapidly progressing your calcium score, you have something else going on. Either the statin's not working or you have progression of atherosclerosis from another source, right? It could be genetics, it could be inflammation, it could be diabetes, who knows? But a high calcium score with or without a statin is a bad thing. And a statin does not affect dramatically the progression rates. As a matter of fact, in the 3 randomized trials of statin versus placebo with coronary artery calcium, there was no change in the progression rates with a statin. So while statins may microvascularly change soft plaque to calcified plaque, it's not seen on a calcium score, and it doesn't change the utility of a calcium score under the influence of statin therapy.
Very good, very good. Thank you for that thorough explanation. If there's no other questions, I'd like to ask to see if Dr. Ashrath is available for any insight or any questions or further discussion.
Thank you. I was trying to unmute myself.
Yeah, sorry about that.
No worries. Yeah, it's kind of a little confusing day because of that. But thank you very much, Dr. Budaf. I appreciate all your insight. Just had I had a question about what are your thoughts about when we report on this coronary calcium scores, when the calcium score is reported, do you think we should also make it a point to report aortic valve calcium?
Yeah, so there are other things that we see that are calcified on a scan. We can see mitral annular calcification, which probably has less prognostic value, at least as best we can assert. It might be a mitral annular calcium, which is easily seen on CT and echo. It's probably associated with large left atriums and AFib. So obviously think about atrial fibrillation as a consequence and then subsequent stroke if you don't treat the AFib. But mitral annular calcium is not atherosclerotic, so probably doesn't warrant much change in things like statins or aspirin or other treatments per se. Aortic valve calcium and aortic wall calcium are both atherosclerotic biomarkers. So we're studying aortic valve calcium. Remember, if you have a high Lp(a) or a familial hyperlipidemia, one of the assessments that say that you have FH is that you have a early aortic valve disease, aortic valve calcium development on your by age 20. That would be familial hyperlipidemia. So aortic valve calcium and aortic wall calcium are both atherosclerotic, and the more disease you see there, the more inclined I would be to be more aggressive with your patient in general for atherosclerotic treatments.
Very well. And I was just going to add a last question here as well that just came through about the value of calcium scoring in athletes, as athletes can have increased coronary calcium, yet considered low risk.
Yeah, so, it's not as, unfortunately, as protective being an athlete, at least with coronary calcium. So the problem is that especially runners get more coronary calcium. Their scores go up. We've seen this in a lot of different studies. And their risk prediction is exactly the same as anybody else. In other words, if a marathon runner has a score above 100, they're 10 times more likely to suffer an MI. And because more marathon runners have scores of 100, in the long run, marathon running is going to be associated with more myocardial infarctions. So just keep in mind the first marathon was run in Greece, and the first marathon runner died at the end of the race. right? That was the story of marathon. So it's probably not the best thing for humans to do. It might be too much exertion, too much bouncing, too much trauma on the limbs, too much inflammation. There's a lot of theories, local stress and stress factors with running. I think running is great, but I think running 26 miles is probably too much for the human body to not have some consequences. And they do get more heart attacks, and they do get more bradycardic events, and they have higher calcium scores. So it's not a paradox. The higher the score, Dallas Hart and Cooper Clinic did nice studies showing if you have a high score with high calcium score and you're a runner, you have the same risk of having an MI as a non-runner with a high calcium score. So it wasn't protective of events, and it did promote more people having a high calcium score. So I think that too much running is probably not a great idea, but I've never been able to dissuade a marathoner from not running their marathon. So I don't address them too frequently. I just show them that they're at increased risk and they need to be on statins and aspirin like everybody else, even though they're running. Remember, Jim Fix, the guy who wrote the book Run for Life, died while running. He didn't want to take a statin. He didn't want to get bypass surgery. He wanted to run his way out of 3-vessel disease, and he died at age 52. So I think you have a runner with a high score, treat them accordingly.
And thank you very much for that answer. And the question that came through right now is, isn't calcified plaque more stable for rupture?
Yep, so calcified plaque itself may not be the culprit, but remember, calcium is the tip of the iceberg. So if you have a lot of calcified plaque, you have a lot of fibrotic plaque, you have a lot of soft plaque, low attenuation plaque, vulnerable plaque, and that's what ruptures. So calcium is not a predictor of the vulnerable plaque. It's the predictor of the vulnerable patient. It's the patient who's at risk of having a heart attack, and because they have a lot of atherosclerosis, and one of those lesions can rupture. But you're right, calcium by itself, if I saw a heavily calcified lesion compared to a scantily calcified with what we call microcalcifications or small partial calcifications, those patients with the small or microcalcifications are at higher risk than the patient who has a huge calcified plaque at that one lesion, the mid-LAD. But the person with a lot of calcium is going to have more events than the person with microcalcification.
Understood. Thank you very much for your time and all the questions. We appreciate it.
All good. Have a great rest of your symposium, and thank you very much for having me on.
Of course.
Thank you very much, Dr. Budov. Again, we understand how busy you are, and especially on this long weekend. Appreciate you taking time out of your busy schedule and doing this work for this lecture for us. Much appreciated. Thank you very much.
Be well.
Thank you. Thank you all, again, to all the attendees for being patient with us as we negotiate some of the logistics this weekend. I'm going to move on to introducing our next speaker, Dr. Karthik Anand. Dr. Anand is currently tenured professor of medicine at Wayne State University, director of nuclear cardiology and PET lab, and the co-director of the adult congenital heart disease program at Henry Ford Hospitals in Michigan, and he's also the president of the ACC. He previously served as director of the ECHO and as the Advanced Cardiac Imaging Program program director from 2011 to 21 at Henry Ford Hospital. He graduated in 1991 as best outgoing medical student at Madras Medical College and subsequently completed his internal medicine residency and cardiology fellowship at Henry Ford Hospitals, Detroit, in Michigan. He received Francis Fernandez Award for Excellence in Cardiovascular Fellowship and graduation. He has completed advanced imaging training in echo, nuclear, cardiac PET, cardiac CT, and MRI, and is currently board certified in all of these. He's a faculty member of the Advanced Imaging section at Henry Ford Hospital and is the 8-time recipient of the Best Teacher Award from the Division of Cardiology at Henry Ford. He has received Distinguished Service Award from Division of Cardiology in 2019 and 2021. And he's active in academic cardiology with over 100 abstracts and papers. He's a member of multiple cardiovascular professional organizations, including the ACC, AHA, ASNAC, ASC, SCMR, SCCT, and serves as the reviewer for over 10 leading professional cardiology journals. He's been actively involved in regional and national level committees at the ACCs, serving as the topic coordinator for imaging diagnostic sessions and imaging spotlight sessions for the ACC scientific sessions. He served on publication committee for the ASC and is currently very active with the ASNAC. He's also served as the chair of the ASNAC Education Committee. He's the co-chair of the ASNAC Board Prep Course and co-chair of the ASNAC 2021 sessions, and served as the ASNAC Board of Directors. Most recently, he was elected a treasurer and executive council member for ASNAC for 2022 and secretary for the Council of Cardiovascular Council of SNMMI, and is chair for the upcoming ASNAC scientific sessions in 2022. Dr. Anand has trained and mentored over 140 cardiology fellows over 20 years and mentored advanced imaging fellows for the past 11 years and is active in educational efforts for fellows and training regionally and nationally. He is the primary investigator for numerous imaging single center and multi-center research trials in echo, cardiac CT, and nuclear cardiology. In his free time, when doing all of these, he enjoys exercise, movies, and table tennis when he has the time. Karthik serves with me on the board of governors, and it's always a pleasure whenever I see him in those meetings. Thank you very much for taking time out of your busy schedule and doing this this busy weekend, Karthik. Thank you.
Thank you, Mahi, for the generous introduction. It is so great to see that we have 30 participants despite it being a Memorial Day weekend. I'm actually destined to work in the hospital, so I'm actually on call for 3 days a week in the hospital. So, but anyway, thanks for this opportunity to Mahi as well as to the Iowa FIT Council. So my goal is to kind of transition from what Dr. Budoff had spoken about coronary calcium to cardiac CT, and specifically just focus on the evaluation of coronary disease. I really have no relevant disclosures for this particular talk. And the outline is going to be a brief refresher on atherosclerosis and where imaging fits in. Just a couple of words on a summary of technological advances in radiation reduction strategies, which has led CT to move forward along with other established technologies. And then we're going to review role of CT in the spectrum of CAD, from asymptomatic, which I won't focus much because I think Dr. Budoff has gone over a lot of coronary calcium scoring. We'll just focus on the symptomatic and prognostic aspects of CT, as well as some of the newer emerging things, including plaque detection, perfusion, CT-FFR, and finally some brief mention of artificial intelligence in CT. So I'm sure many of you have seen a diagram similar to this with regards to the progression of atherosclerosis from early intimal thickening to development of the plaque, leading to fibrous cap atheromas, formation of the thin cap fibrous atheroma, with lipid-rich plaque in the center, which ultimately leads to coronary calcification and fibrocalcific plaque. So I'm sure you heard already that calcium formation is over the years. So when we see calcified plaque, things have been happening for a while before you've reached that particular thing. And so the natural history of atherosclerosis is defined by minute stresses on the plaque, which happen in one's daily life, which luckily in many patients undergo actually spontaneous healing and then calcification to stabilize the plaque. In unfortunate scenarios, you can actually have erosion, thrombosis leading to acute coronary syndromes. Now, when you marry the atherosclerotic findings to anatomic technology, and we'll talk about physiology in a minute, you can see where cardiac CT and coronary calcium fall in. Some of these invasive technologies can primarily look at plaque a little bit earlier, but as you start accumulating plaque, particularly if you talk about coronary calcium, really you need to have calcification for you to see that. Whereas cardiac CT primarily is able to evaluate not only calcific plaque, but also non-calcific plaque. So it has the capability of identifying early non-obstructive atherosclerosis, which is a significant advantage. Now, I use this diagram often to teach residents and fellows with regards to where imaging fits in with coronary physiology. And this is kind of key. As you can see at the bottom, we just saw the progression of atherosclerotic plaque. Here in the x-axis, it's coronary stenosis from 0 to 100%. And on the y-axis is flow. Now, the normal resting blood flow is about 1 ml per minute per gram. And that's why across the range of stenosis, most people do not have any ischemia in daily life, unless you reach a critical point of significant stenosis where you start developing ischemia at rest or with minimal exertion. And when we've fundamentally done stress testing for decades, we, in some way or the other, challenge the coronary flow reserve to actually identify those who have ischemia or a problem with distribution of hyperemic blood flow. The biggest problem we've always had is we have been able to test the coronary physiology only in lesions which are obstructive. And all of us have realized over the past decades that the disease process spans the entire spectrum of obstructive to non-obstructive atherosclerosis, which stress testing routinely misses. And we've heard multiple stories of people with normal stress tests who have had events. But with the advent of coronary calcium scoring and CT, I think we have been now able to marry the anatomic and physiologic technology by being able to detect not only ischemic areas, but also the atherosclerosis in its entire extent. So I think it's, rather than always hearing CT versus stress testing, etc., I think the goal as we kind of try to integrate these images into daily practice is to see how we can best utilize all these technologies current in the right way. But as you can see, we are now able to test the entire gamut of coronary atherosclerotic disease. So when I look at cardiac testing and how to choose testing for different patients, I look at diagnosis versus prognosis. So number one, when you're looking at diagnosis, we need a test which is able to reliably tell us whether there's presence of disease, what is the extent and severity of the disease, and what is the what is the likelihood when we do this test by Bayesian analysis or pre-test likelihood, however faulty those things in a way could be, could predict the disease correctly. When you look at prognosis, once you know that the patient has disease, we want to know what is the likelihood of an event in that particular patient, and is it going to be a significant issue based upon the information that the particular test provides us? What is the extent of problems that this patient is dealing with? And what is the incremental value of the test when you consider this? So I would encourage anytime you think about ordering a test or go into practice is to kind of approach any disease process with what the primary fundamental goal of the test is. So with that in mind, when we look at cardiac CT, and you're going to hear various aspects of CT, in lectures coming up, I think next week too, we're going to focus primarily on coronary artery disease diagnostic assessment as well as prognostic assessment. And during that time, obviously talk about the role of CT in multiple areas of CAT. We're not going to be addressing any of these, but we know that CT carries tremendous value in multiple of these additional non-coronary disease processes. Technology-wise, one of the reasons why CT has made it fast into the front line is the rapid growth in technology. So you can see when initially it was started, we had very few rows of multi-detector CT, which took a long time to scan the heart. And typically when we talk about scanning the entire breadth of the entire heart, we're talking about probably about 12 centimeters of coverage. So as you can then imagine over the years, as the number of rows in detector technology has increased, we now have reached the point where we can actually scan the entire breadth of the heart with a single rotation due to the advancements in technology. So that is reflected in this diagram here, where you can see how as technology has advanced in CT, you are now able to capture the entire heart in its volume to be able to reconstruct it pretty fast. And so by thinking about this, you can then imagine how some of the limitations of CT with breath holding, rhythm problems, etc., can potentially be overcome when you're able to scan the heart so fast. not only is it that aspect of technology, one of the other reasons why coronary CT has moved forward is the advancements in technology and radiation production. So you can see here A through G named right here, multiple ways to actually reduce radiation has happened, starting from close to 15 to 20 millisieverts in many years ago to now, if using dual source high pitch CT, which can actually do a complete coronary CT in with less than 1 millisieverts. But the workhorse of CT, obviously across the United States and in most places, is still a 64 slice CT. And so with a 64 slice CT, adapting prospective acquisitions, keeping your doing ECG modulation, and in patients with a lower BMI, even reducing your KEV and not using padding, all of that has brought CT to the front line, comparable or even better in many situations with other imaging modalities to be able to use for coronary artery disease. And so here is just an example of one of the studies published by Dr. Achenbach some years ago, showing that with prospective helical CT acquisition using a high pitch factor from 3.4, which looks at stable movement to rotation, using single heartbeat scanning, you can scan the entire chest for looking at coronary arteries with just under 1 second, with the radiation of less than 1 millisieverts. Now, obviously, we can't do this in all patients; those who are obese, et cetera. But in general, this is now an achievable target. So now, moving from technology to the spectrum of CAD, we typically approach CAD in 3 aspects. Is the patient asymptomatic, in which case we primarily look at prevention? You've heard a lot of that from the previous lecture, so we're not going to focus much on that. We primarily do targeted atherosclerosis imaging using coronary calcium, which definitely is the best screening test available, receiving a class 2A indication from ACC in selected patients. And again, this I think is evolving, as we all know that we still utilize the risk scores or risk analysis like the pooled cohort equation, etc. And then there are other scores available across the Atlantic. Although we are continuously learning that coronary calcium score seems to redefine, as well as cardiac CT seems to redefine these risk scores, which tend to sometimes overestimate atherosclerosis. So for example, you think a patient is high risk, you do a calcium score, their calcium score is 0. Their risk reduces and you could alter your treatments according to them. Kind of cardiac CT also fits in that same way, particularly in symptomatic patients and those with known disease. Now, I'll just make a brief mention. You've definitely heard this, and I think I caught the last part of it, looking at the value of a 0 coronary calcium score. And we're talking about asymptomatic patients. We don't need to go through this data in great detail, but we've learned that the coronary calcium score of 0 definitely is among the best things that someone can have with regards to risk prediction. And regardless of which data you look at, and I've presented some of the data here with thousands of patients, you can see that the long-term risk prediction is low. However, we are continuously learning, and it's not that it's a deficiency of coronary calcium, but we know that coronary calcium primarily looks at calcified plaque. So it's not perfect, and there is caveats in certain groups like very young people, etc., where coronary calcium has not had time to develop, or for example, even in certain groups like South Asians, etc., where soft plaque development may be much more prominent in these people. So coronary calcium score of 0 is great, but may not be always perfect in some groups. And you can see this most recent study, which has come out from South Florida. We're looking at close to 2,500 patients, mean age of around 53, with 50% being women, all free of clinical cardiovascular disease, and they all underwent a baseline CT. And then the non-contrast CT was used to look at coronary calcium, but the contrast-enhanced CT was useful for plaque determination. And the long story short, as you can see at the bottom line, that if your calcium score is 0, you still have prevalence of plaque, for example, non-calcified plaque, or stenosis. These are small numbers, but just tells us that there are going to be small subsets of patients where calcium score may not identify a non-calcified plaque, which is kind of understandable. But I think it's important to realize that particular aspect. Now, when you come to symptomatic patients, obviously we won't be able to review all the literature in detail, but I put this up just to show you that the reason why CT has received high marks in the current guidelines, which we'll go through, is the number of trials which have looked at it, CT versus stress testing, which shows that CT is at least as good as stress testing, as shown in the PROMISE trial, and in the Scott-Hart trial, which was the UK-based trial, showing that the data from CT likely led to targeted treatment, which caused reduction in events. And then, so if you look at the PROMISE trial, for example, CT versus functional testing for death MI, unstable angina, and major complications, there was really no difference. And when you looked, then looked at death or non-fatal MI alone, CT versus functional testing matched up very well. Now, every single trial we won't be able to go in has its caveats with regards to limitations in how the trial was done, patients recruited, etc. But in general, the take-home point in these trials has been that CT helps to identify greater disease. No surprise, it's an anatomic technology compared to stress testing, so it's able to look at that entire gamut of atherosclerosis that we talked. And CT-driven cardiac catheterization led to higher level of revascularizations. And this is a consistent trend where you say CT tends to lead to more coronary revascularizations, and in some studies, cardiac catheterizations too. Now, the Scott-Hart trial is interesting. It's actually the first trial to determine the effect of CTA on the clinical assessment of patients presenting with suspected angina. So I'll just show you how the Scott-Hart trial was done. And in this study, just for those of you who are not familiar with it, 85% of these patients actually underwent exercise ECG. So these patients were primarily in UK, for those of you who are not aware, you have to see a general practitioner based on the National Health Service policy to be able to actually then subsequently refer to testing and specialist reference. So these patients had a history, clinical examination, 12-lead ECG. Close to 85% of them underwent exercise ECG if the clinician suspected that they could have an angina. And then they were approached, depending on for study inclusion, and they underwent an angina questionnaire, and they were randomized to CT plus standard of care versus just versus just routine assessment. And then what happened was this coronary CT results were then turned back to the attending clinician, and a 6 weeks review of the attending clinician was done to see what the diagnosis, investigations, and treatment plans were made on CT. And then the patient was again interviewed post-CT for angina question after all of this was done. So if you think about it, this is a realistic, pragmatic trial, is how a general clinician utilizes the CT data. And when you look at the initial follow-up of the Scott-Hart trial with regards to death and non-fatal MI, you can clearly see there is a trend towards CT being better than kind of standard of care, although the p-value is kind of borderline in both for both endpoints in general. And if you look at coronary angiography, there was no difference, but coronary revascularization, as we talked before, was higher in patients who underwent cardiovascular CT. So one of the initial conclusions of the Scott-Hart was it tended to clarify the clinician's thought whether the patient had angina or not, to clarify the actual diagnosis in 1 in 4. It increases the diagnosis of CHD, no surprise, because it looks at atherosclerosis, but it appears to reduce the diagnosis of angina due to CHD. What does that mean? If you initially thought a patient had angina and then you did a CT, but then the CT doesn't show any obstructive disease, then you wonder whether the angina was not truly angina or it was something else. Now, I'll pose a caveat there in the sense that angina is not all due to epicardial disease, and we know that. And that's kind of one of the limitations of CT, right? If you think about it, it's great with all of the technology and FFR and stuff, but we now know that 30 to 40% of patients, particularly women who have angina, do not have epicardial obstructive disease, but have microvascular disease. So I think that's That's the Achilles heel of CT, saying that just because you don't have obstructive disease, the moment you do a CT, it's not like you're scot-free. The patient really doesn't care what you think about it. They want to know the actual diagnosis. So you have to be able to figure out if the pain is truly cardiac. Could it be microvascular, or could it be esophageal, or something else? And in this particular study, CT did alter subsequent investigations in 1 in 6. It changed treatments, which is probably the reason why in the long-term follow-up, which I'll show you later, Scott Hart showed that patients who underwent CT had reduced event rates long-term. And the main reason for that, it's not just because you do a diagnosis, you get reduced events. You take actions based on it. So detection of atherosclerosis leads to statin initiation, aspirin initiation, which subsequently translated to reduced event rates. Now, this is hot off the press, and some of you may have already seen it. This is the discharge trial, which was just published in New England Journal of Medicine, looking at the value of CT versus cath in stable chest pain. These were about 3,500 patients. It's kind of a funny intermediate pretest likelihood, I would say. I mean, typically, if you look at the Diamond Forrester, that's like 15 to 90%. So here, the pretest likelihood was decided as 10 to 60%. These were stable chest pain patients. They had a 3.5-year follow-up. And the bottom line was, if you look at CT-based strategy versus invasive coronary angiographic strategy, there was no difference in major adverse cardiovascular outcomes. Not surprisingly, those who underwent cath had a slightly higher procedural-related complications compared to the CT group. Now, one of the caveats I would mention in this trial is only about 13% in the CT group and 14% in the other group actually had any kind of higher risk anatomy to actually warrant any intervention. But the take-home message of the discharge trial is CT seems to do as good as invasive angiography in the initial assessment of a patient with stable chest pain. Now, what about acute chest pain, which is a slightly different scenario when patients come in, and there's a wealth of data on CT. So you can see the CT, our group here, local group here from Beaumont Hospital led the CT STAT study, as well as the other study that is here, as well as there are numerous other studies, including the ROMICAT study, where CT has been evaluated in acute chest pain. And the take-home messages there, I would say, in all of these studies is a CT-based strategy compared to a standard of care, which is like stress testing strategies, serial troponins, etc., is associated with earlier discharge. Like, no surprise, you do a CT after the first troponin, it shows no disease, you're able to discharge the patient home rather than do serial troponins and wait for a stress test to come back. And then there were also obviously more diagnosis of any kind of coronary disease, right? Because you're looking at anatomy in general. However, if you look at across these studies, there is no study which has clearly shown that CT is superior to stress testing for prognosis and other things in acute chest pain scenario. It definitely is a great test in the selected group, particularly low to intermediate group where you want to get rid of it. Now, if you look at the ROMICAT data, CT has also helped, sub-studies of that has also looked at the culprit lesions which happened. They looked at patients who had an ACS and compared the CT data with regards to culprit lesions to identify that those culprit lesions on CT could sometimes predict the acute coronary event syndrome, but the positive predictive value of that is pretty low. So to summarize, with regards to the value of CT in coronary disease, the technology is superb, particularly for its negative predictive value, right? So you can see the sensitivity of CT is close to like in the 98, 99%. CT does suffer from a slightly lower specificity. This has varied quite a bit. The literature is anywhere between 70 to 90%. And part of that is because of the fact that when you see a stenosis in CT, not all the times is it functionally significant, and so there are false positives can also increase due to increased coronary calcium, image quality issues, etc., etc. So it's great as a rule out, and it's pretty good as a rule in, with the caveats that sometimes you can have much more false positives. And we'll talk about how that has been solved to some extent in the line. Now, I put this one at the side showing that we always think about atrial fibrillation as something where CT cannot be done, particularly with the newer scanners with rate-controlled AFib and the whole heart scans with a few heartbeats. You can actually get pretty good sensitivity and specificity with CTs. Obviously, the more irregular your rhythm is, the more ectopy you have, the less accurate CT becomes. So as a comparison to other tests, you can see right here, CT does very well. So you can see it's got a sensitivity of 97 to 99%, and the specificity, as I mentioned to you, is quite variable compared to many of the standard technologies that we use. And you can see why exercise ECG, even though it carries dramatic value in giving you exercise information, I think it's still very valuable. Our ACC guidelines still kind of continue to recommend that. But if you go across the Atlantic in Europe, as well as, for example, in UK, they have pretty much retired exercise ECG as a modality for coronary disease testing. If you look at the NICE guidelines and the update which came out of UK, exercise ECG is no longer recommended because of its unacceptable sensitivity and specificities. And the UK guidelines actually recommend CT as the preferred modality for chest pain evaluation. So what does our guidelines say? So the 2021 ACCHA CTA recommendations, CTA has got a class 1 recommendation for intermediate risk patients with acute chest pain and no known CAD, and particularly if they've had a negative or inconclusive evaluation. And this is exactly what I tell our group here, and I teach our fellows, is like, I have never done a stress test again if a patient has already had a stress test in the last 2 years. Very rare scenarios where they cannot undergo an anatomic evaluation. I think definitely those patients benefit from CT if they can have a CT, versus if they come back and they have a high suspicion for coronary disease, potentially coronary angiography if needed in the acute setting. But I think this is where CT really has its strength, clarifying prior negative or inconclusive evaluation, particularly in patients coming back with chest pain. Now, in patients with intermediate risk acute chest pain with no known CAD and prior evaluation, CT has received a class 2A for excluding the presence of atherosclerotic plaque and obstructive disease. So class 1A, as you can see right here, and class 2A for this particular group. Now, in patients who have had CABG and stents, as we all know, there are some limitations, which CT is wonderful for graft evaluation. As you know, the vein grafts really don't have that much motion as that of the native coronary arteries. So if you're looking primarily for graft definition, CT is great, although we may struggle a little bit at the clips area where the graft has been inserted, as some surgeons do that. Stents continues to be a little limited, particularly if your stents are less than 3 millimeters. With regards to blooming and other things, but the technology is continually improving and things may change over the period of time. But in general, at least in our institution and in most institutions, CT is not recommended if you've got very small arteries and stents, because it's difficult to read within the lumen. And then if you think about bypass surgery, CT assessment of native disease is a problem, right? There's going to be native disease progression. To assess that is going to be pretty much challenging. So I think it has to be carefully chosen to use it in established significant coronary disease, because I think functional testing is very valuable in that particular scenario. Now, if you look at this meta-analysis, looking at multiple tests with regards to pretest probability of ruling in or ruling out CAD, I'll kind of try to direct your attention to a couple of things. So if you look at this particular study, which looked at pretest probability of CAD, this is a meta-analysis. You can see that across the board of pretest probability, green being essentially rule out and red being ruling in CAD based on pretest probability. You can see that CT does very well across the board of pretest probability. Even if you thought a patient had intermediate to high likelihood of CAD, you did a CT, CT can effectively rule out significant CAD. When you take, however, when you take stress testing of various kinds, you see that they don't perform as well in patients with low to intermediate likelihood of CAD. This is one of the Achilles heel of testing, stress testing, where CT dominates compared to stress testing, because the lower the pretest likelihood, the greater is the likely you're going to get false positives in these scenarios. So you can see how these technologies work in complementary rather than competition. When you come to this side, looking at pretest probability for predicting FFR significant CAD, there you can see that technologies like stress testing, particularly PET or stress MR does pretty well in actually predicting it compared to coronary CT, where you can see that coronary CT actually predicts significant FFR disease only in very high pretest probability of disease. So I think this is where functional imaging should be married into anatomic imaging, looking for functionally significant disease. Now we know that CT has also redefined quite a few things. We always used to do Framingham score, and now we do ASCVD score. I think we have systematically overestimated prevalence of disease. So you can look at this one. This is actually prediction of disease based on observed disease rates. So if you look at no obstructive CAD, if you just use your risk analysis, you would have predicted anywhere between a 10 to 15% event rate. But you can see that by doing a CT showing no disease, you've actually reduced their likelihood of event rates much lower. And the vice versa applies for obstructive CAD. So anatomic information has helped us rethink which patients are truly at high risk rather than saying, well, you're high risk all the time and implementing therapies in them. And this is where the de-risking concept comes in. And I'm sure you heard that with coronary calcium score. What about prognosis of CAD? Now, CT has done a lot of strides in prognosis, because we always used to think, well, it's good to know the diagnosis, but what about prognosis? We need stress testing. Now, stress testing is still very powerful in that, but CT has actually gained a lot of ground in that. And part of that reason is because we have learned over the last decade or two that it's not only obstructive CAD, but non-obstructive detection of that 0 to 50 or 60% of disease I showed you in the diagram earlier now carries prognostic significance, because a lot of the MIs seem to happen in patients without any significant CAD. And that's primarily because of the plaque characteristics that we're dealing with. You know, they are lipid-rich plaques, they have a thin fibrous cap. These are things that are not picked up routinely by stress testing. And so CT has actually made inroads. Very similar to stress testing, you can see that as your disease severity increases, the prognostic significance increases with regards to adverse events with CT. And the same has been shown with, and this is kind of the same thing, even if you have non-obstructive disease. And this is data, again, coming from the confirmed registry, looking at primarily patients just with non-obstructive atherosclerosis, but based upon whether they have 1, 2, or 3 vessel non-obstructive disease. So you can see that even if you have non-obstructive disease, the extent of non-obstructive disease still seems to drive event rates. Now, coming back to the Scott-Hart trial, and the reason I kind of waited to put this is the Scott-Hart trial showed the initial follow-up, which I showed you at 1.7, but then they looked at long-term prognosis, which is data which came out not too long ago, and they essentially showed that CT-based data, doing a coronary CT was associated with reduced event rates. So obviously we know that, well, why would a diagnostic test lead to a reduction in event rates? And it turns out that a lot of it is the fact that the moment the clinician recognizes there is atherosclerotic plaque, they make a move towards implementing statin therapy. And that is, I think, one of the Achilles heel for stress testing, right? You tell your patient, well, your stress test is normal. Everybody thinks that's cool and dandy. The referring physician says, well, the stress test is normal. I don't need to do anything. Well, but we are not assessing atherosclerosis. We are only assessing functional significance. And I think knowing the presence of atherosclerosis, whether it's functionally significant or not, helps to make a treatment strategy decision better. And so when you look at non-obstructive disease and symptomatic patients, this is the new guidelines against coronary CT and or stress testing all of them receive a class 2A indication. And I think this is important to realize, because I think CT, once you detect non-obstructive disease in CT, you implement strategies, right? But what if the patient continues to have chest pain symptoms? I think that's where functional testing is key, something like cardiac PET or stress MR, which can look at microvascular dysfunction, because I think you can't just write off a patient just because a CT doesn't show any obstruction, because there is much more to coronary disease than epicardial disease. And I think there's a lot of misconceptions based on the ischemia trial. I won't be able to go into all of that in great detail, but people believe that, well, I'm going to do a CT, rule out left main disease, and then I'm all set. That's fundamental misconception, because The ischemia trial never evaluated technologies. It only evaluated whether a goal-directed medical therapy versus revascularization in moderate to severe ischemia was used. CT was just used to define the exclusion of left main disease. So I think it's important to know what is causing the chest pain, utilize CT for detection of any atherosclerosis, which makes a big difference, and utilize functional testing as needed if patients continue to have symptoms. So moving on to how do we use CT for actually making decisions for treatment. So this is a nice diagrammatic form where once you know whether the patient has disease, mild disease or significant disease, you can start giving recommendations. If the patient has no disease, and I've modified this a little bit, I would not only give reassurance, I would basically say, well, we need to figure out what's the etiology. So I would probably let the primary physician know, work up esophageal etiologies. Or if the patient has still classic anginal pain, I may do a microvascular disease assessment. So it's just writing them off is good for us, but it's not good for the patient. Now, when you come to obstructive disease on the other end, you have to decide whether that obstruction is actually causing things. This is where CT traditionally struggled, right? Because if a patient has chest pain and I do a CT and it shows a 50 to 70% lesion, how do I know that 50 to 70% lesion is actually causing that patient's chest pain? Because typically a 50 to 70% lesion at rest should have normal flow, as I've shown you in the diagram before, so they shouldn't be having active chest pain unless the plaque is unstable. So this is where functional testing kind of has predominated, and now FFR-CT has come through. So this Achilles heel of CT, where you have moderate disease, which then puts into question the value of the disease, has now been filled by FFR-CT. So what is FFR-CT? So FFR-CT is, I think it's a unique technology, no question about it, where you are actually simulating hyperemia, because we do the entire analysis based on a resting CT. We're not doing any hyperemic challenge. So we take the data of a good quality 64 slice CT, which is kind of the minimal requirement that you need, and then you send it off, and then multitudes of things happen with that FFR-CT. So the first thing which happens is these things get uploaded. The CT data gets uploaded into a computer. As you all know, this data is sent to one particular company, which actually does this at this particular point, which is called HotFlow, and they build an 3D model of a coronary tree. Multiple factors are then taken into account, which includes resting coronary flow, which is calculated from the myocardial mass, the microcirculatory resistance, which is based upon the size of the vessels that you get on CT, and effect of simulated adenosine-like hyperemia, which we don't use adenosine, but it's a model which is actually generated. And then the fluid properties, the viscosity and density of the fluid is also taken into account. All of this is fed into a supercomputer, and I don't claim to know the physics equations on this one, but the fundamental equation which is used in solving this is called the Navier-Stokes equation. And this supercomputer then generates this data, and obviously this is double-checked by the technologists to make sure that the data is tracked accurately before being released back to the referring doctor. So the biggest problem I have with this is that I'm not involved in the actual thing. But I don't claim to have to be involved in it, but we send it out and then we get it back. But I'll just share with you what the data has shown so far. So you can see, again, this is again looking at multiple studies, looking at the value of FFR-CT, and particularly one study, if those of you are interested, you should look at the Pacific trial, which looked at multiple technologies, SPECT, PET, CTA, CT-FFR, etc., which actually showed that FFR-CT is excellent and comparable to, if not better than, many of the other technologies. So there is a wealth of data in FFR-CT, and the reason I show you this is that FFR-CT is now reflected in the guidelines, so we need to know about it. Why did that happen? Well, at least data suggests that if you combine CTA with selected FFR, you can actually lead to reduction in unnecessary coronary angiograms. Because think about it, the moment we see a 50 to 70% stenosis, we're going to start referring those patients for CAP because those patients came in with chest pain. But when you combine that with FFR functional assessment CT to see if that is truly significant, your cath rates go down because your negative FFR has been shown to be very valuable in and associated literally like the DIFFER, the FAME2, the Sweetheart studies, whichever one you should look at invasive FFR studies or IFR studies. The primary goal there was to defer treatment, right? Now, CT FFR has shown the same thing, where if you have a normal FFR in a 50% lesion, it has been shown that it's safe to defer those patients from coronary angiography because their event rates are pretty low. So you can look at this particular one, looking at obstructive versus non-obstructive CAD, usual care versus FFR CT guided. There was FFR CT was able to do a significant reduction in routine referral to coronary angiography. So what are the strengths and limitations of FFR? So obviously its strengths are that you don't need any stress analysis. You just use your existing data, do a simulation with computer and deep learning technologies to be able to get this information. It provides measure for lesion-specific ischemia, no question about it. There's no additional radiation costs or medications. And it's pretty fast and well tolerated because the only thing you're doing is a CT. And the technology of FFR has advanced so much that typically it used to take hours to get this data. We can now get this data back in literally like 2 hours from the outside source. And so the limitations, as I see, is it's offsite processing. It is the data. You can't do anything. You cannot you can question the data, meaning you can go back and tell them, listen, I don't think this is accurate, and they will actually do a due diligence check. They will get your patient data and review it. You really need adequate CT image quality. If your CT image quality is poor, your CT FFR data is questionable. They may not even do it for you. High calcium could be potentially associated with issue. And we don't have long-term strong comparable data with regards to clinical efficiency outside these trials. And then more caveats is that stented vessels, bypass grafts, patients with contraindication to nitrates, because you really want the arteries, the size of the vessel is factored into the FFR CT calculation. So you don't want vessels to be pretty small. And you don't want to be doing it in acute coronary syndromes where there is quite a bit of issues with microvascular issues and stuff. Now, one of the trials which put a temper on CT FFR is the FORECAST trial. And this is a very recent trial which basically took patients with stable chest pain in a rapid access chest pain clinic in England and Scotland and randomized them to CT alone with selected CT FFR versus standard group, meaning you just do CT followed by stress testing or angiogram, etc. And the long story short is there were actually no differences in between the two modalities, meaning there was actually no difference in total cardiac cost. There was no significant change in improvement in angina. Secondary endpoints was quality of life was not good. The only thing was that there was a 21% reduction in cath in the experimental group. Kind of same concept that I told you, that CT with CTA by itself or CT with selected FFR can lead to reduction in cath. And 52% of fewer patients with non-obstructive CAD on cath in the experimental group actually. So essentially, when you had non-obstructive CAD in cath, that on CT, that led to much less cath. So this is a damper. And what I would say, the take-home message from the FORECAST trial is that I don't think we should routinely. I don't think you need to routinely do CT FFR in every single patient. If you take the data from the ischemia trial and the data from the FORECAST trial, I would basically conclude that if I'm not dealing with significant angina and I have a patient with an abnormal stress test with moderate to severe ischemia, I start with medical therapy. If you have a CT data, that is great. You start with medical therapy. And if the patient continues to have symptoms, you could send that CT data back for FFR, see if the FFR is positive, and then recommend coronary angiography based on that. That is one take-home point to do that. And the reason why I say that is, remember that when you do CT FFR, that adds about approximately $1,100 to $1,200 cost. So cost is always an issue when you routinely do additional evaluations. So where has CT FFR made it? The CT FFR has made it into the guidelines, as you can rightly see here. Stable chest pain with known CAD. If you have obstructive CAD, obviously, first thing would be to make sure that you have adequate testing. And if you do not, if you essentially have, if you have adequate medical therapy, if you still have frequent angina, as I was telling you, these patients could be considered for invasive angiography of FFR, and CT can be selectively used in those cases. So I think FFR CT is here to stay. The technology is getting better. It can be used for both obstructive and non-obstructive disease, but it should be selectively done only if patients have moderate lesions where you're not sure, or the patients continue to have symptoms despite good medical therapy. In the last 15 minutes, I'll just kind of go over some of the advances in CT. So we're not going to talk much about stress CT perfusion. This is there, but I don't think it is widespread. We don't do it, but primarily because there are so many other technologies which can give less radiation and less contrast. But stress perfusion CT has been widely done too. It's just the same as when you look at a perfusion defect with stress vasodilator compared to rest. You can either do stress perfusion first, followed by rest versus stress. So both can be done. It's got its strengths, but I think the bigger limitations is what prevents me from implementing it routinely in our institution is its artifact. It's definitely got lower contrast resolution than SPECT or even cardiac MR or PET for that matter in general. Ionizing radiation, obviously, you need to have a larger contrast dose. So all of those pose problems for me, but the data is there. So for those of you interested, I put in a reference here, which is pretty recent, looking at multiple studies, looking at CT perfusion. And I think, technology continues to improve, so it's very possible that things may change down in the future. But currently, I don't think this is mainstream. But the most exciting area, I think, in CT is plaque assessment, where we've talked about all of these things, but what about the histology of the plaque? As you can see right here, CT has been used to assess plaque progression, meaning you do a CT, this is, for example, in 2012, you initiate therapy, and then you repeat CTs. So you can see that this kind of lesion, which is essentially got a mix of non-calcified and calcified plaque over the years, has become primarily like calcified plaque in general. And so this brings us to plaque volume and composition assessment with CT. And you may have heard part of this from Dr. Budoff, if you look at what happens in patients with elevated coronary calcium score, you can see that as the calcium score increases, the soft plaque composition, which is shown in the red, decreases, and the calcified plaque obviously increases. So there is interesting studies, particularly coming out from the CONFIRM registry, which is called the ICONIC study, which introduced the concept of 1K plaque. 1K plaque means those with a calcium score of greater than 1,000. When they looked at the culprit lesions of these patients who had ACS, they showed that those who had markedly elevated calcium scores had the lower ACS culprit-based disease, suggesting that a significant amount of calcium may help to solidify the plaque and prevent acute rupture. CT has also been used to follow the treatment responses to statin. So here you can see statin-naive patients at baseline and follow-up compared to statin-taking patients evaluated by CT. And no surprise, as was said in the previous lecture, the patients with statin, when you follow them with CT, have progression of coronary calcifications in general as the composition of the plaque changes. And this was shown in the paradigm study where CT was used to assess disease progression. So this is an exciting area where CT can be used to assess the various kinds of plaque. We've learned that low attenuation plaque is kind of a higher risk marker. And you can see right here, patients who went on treatment go from a low attenuation plaque to a more calcified plaque right here, red being low attenuation. And so these are all the high risk features which have been defined by CT: low attenuation, positive remodeling, spotty calcifications, and napkin ring sign. And so when I read these, I show the fellows and residents and we discuss all of this. This is great that we are getting this vulnerable plaque versus vulnerable patient concept. But where I struggle with this is if you look at all studies which have looked at these vulnerable plaques, is the actual number of events in patients with vulnerable plaques is extremely low. That is, in an individual patient, you cannot accurately predict that that patient will have an event just because he's got a low attenuation plaque. That is the problem. On a population basis, it's great and it shows some trends, but it is not a great predictor of individual patient events. So I still don't know what I would do with this information if I get it back. I mean, I would anyway use statins because the patient has a plaque. I would make sure they are well, the LDL is well controlled, but do I follow them at 3 months because they have a low attenuation plaque versus 6 months? I don't think we know that. And there is numerous softwares for these available out there, the vendors. So you can definitely look them up. These look at the plaque volume. They look at what is low attenuation, what is fibrous, etc. But these are all very exciting things where we are able to evaluate the plaques, but they're not routine mainstream at this time. And then in general, you can see that I believe plaque burden and plaque assessment is here to stay. This is actually data coming out of 24,000 patients in the Denmark Heart Registry, which actually showed that regardless of whether you had obstructive CAD or non-obstructive CAD, it didn't really matter that it's actually plaque burden, not stenosis per se, which actually drove events. So you can see right here, both obstructive CA and non-obstructive CA patients had equal amount of calcium in the study, and their risk really did not change much. So just because you have non-obstructive coronary disease doesn't mean they're at a lower risk. That's kind of one of the take-home points in this one. Where I think is more excitement, and I think there's more data coming out, is what is called high attenuation, what is called DCAT, which is basically vulnerable, the perivascular fat around the coronary arteries being inflamed. And so this is data coming out of assessing fat attenuation index by CT. So you take these vulnerable plaque features and then you look at the pericoronary tissue to calculate the amount of inflammation in those tissues. So those with low fat attenuation index had lower event rates compared to those with high fat attenuation index. So I think these are some of the data coming out of the CRISP CT study, looking at these. So this is exciting again in coronary disease and CT assessment. So you can see there's a lot of research going on. Although these are not all mainstream, I just wanted to let you know that these are some of the exciting things that are coming down the pipeline with CT. So I'm going to summarize this by essentially saying that coronary CT has got numerous advantages. Diagnosis, detection of obstructive versus non-obstructive plaque, treatment strategies, treatment response, emerging applications of high-risk plaque, CT FFR, as well as pericoronary attenuation index. So I think it's here to stay, and I think it should be used in complementary role along with FFR CT and stress imaging so that we can do the best for our patients. Thank you very much for your attention, and I'm happy to answer any questions if I can.
Thank you very much, Dr. Anath, for the very thorough and comprehensive discussion. It was a great follow-up from the lecture before this. There is a question here in the chat box. The question is, what is the extra cost of CT FFR for patients? And is it reimbursed by insurance companies?
Yeah, so I think I mentioned this. So at least, again, it's varying state by state and insurance by insurance. So I won't be able to give you the detail on each and every insurance. At our institution, CT FFR is not done typically for inpatients. It is primarily only done for outpatients because insurance reimbursement for inpatients, as you know, is DRG. It takes the entire hospitalization into account, but it typically runs about $1,100 extra if you order a CT FFR.
Oh, okay. Okay, thank you very much. And I had a question of my own. Is there the role, how are we seeing the role for triple rule out scanning, for example, to rule out, let's say, an acute coronary syndrome and aortic dissection and PE? Are we seeing a superior role of cardiac CTA on this?
So there is data published from the BCBS, which is the Blue Cross Blue Shield in Michigan consortium, which had the CT consortium on triple rule out. So obviously CT is great, as you mentioned, because it can look at multiple things apart from coronary disease. First, I'll address the technological and the performance aspect of this. It's important to remember that when you plan a triple rule out, you are going to give more contrast, and you have to actually plan your acquisition accordingly, because you have to opacify the right system to look at the pulmonary vasculature because you're trying to rule out PE. And then following that, you have to opacify the left system. So which means you're going to have to give more contrast, and your entire assessment is going to be, a certain magnitude more complex. That's number one. The point I would, and so CT is great. So you can, if you did it completely, you're going to get a little bit higher radiation. You get a little bit more contrast for the patient, but you can rule out those technologies. I don't think it's mainstream. And the reason why I struggle with that is, if I go to assess a patient, if I cannot make a decision if the patient is having aortic dissection versus a PE versus ACS, I find that myself a fundamental problem. I think as clinicians, we have to be able to say, the likelihood that this patient has this one. So using your clinical risk scores for pulmonary embolism, aortic dissection likelihood, I think is important. It is doable. I would discourage it because it is, it is associated with higher radiation and contrast, but the technology is awesome. And the answer to your question is it can be done.
Okay, thank you very much. One more question. Should we use FFRCT in acute chest pain, leaving the reimbursement aside?
You're talking about suspected acute chest pain or actual ACS ongoing, like a non-STEMI?
I believe they're saying ACT ACS. I think so.
I'll actually address both if you want.
Okay.
So
Okay.
in suspected ACS, absolutely, meaning if you had a patient who came in with suspected chest pain, first troponin is indeterminate, you do a coronary CT and you find a 50 to 70% lesion, FFR-CT will definitely help you in that particular angle, because if your FFR is negative, that is great. But it doesn't mean that the patient will not go on to have a non-STEMI, right? Because we know that they can have plaque erosion and still have a non-STEMI, even though they don't have obstructive disease. So I think it can be used, but assuming it could be reimbursed and stuff. If you have proven disease, like the patient actively has non-STEMI, I would discourage the utilization of that based upon the literature, right? So if you have a patient with rising troponins, that patient needs to go to coronary angiography. And plus, you are trying to simulate hyperemia with FFR-CT. And we know that even invasive FFR struggles in the setting of acute coronary syndromes, right? Because the entire coronary tree is inflamed, the microvasculature is dynamically changing. So even invasive FFR has to be taken with a piece of salt when you try to actually do it in multiple coronary territories at the same time. And I would definitely say I would not recommend doing FFR-CT in an ongoing non-STEMI situation.
Very, very good points. I personally have learned a lot from this lecture. Are there any other questions or comments from the audience or?
Hey, Karthik, thank you very much for doing the talk. Very informative. I just had a quick question about FFR-CT. Is there, initially at least there was quite a bit of turnaround time to get the results because of the data analysis and all. How is it now? Like,
it's actually excellent. I have to say it's coming down. It was close to. It used to be 4 to 6 hours before, which made which obviously for us to make a decision in the chest pain unit would be challenging. Right now, we can order it as a stat. So if you put in it as a stat, the turnaround time is 2 hours or under. Yeah.
That's awesome. And then the 1100 you mentioned is in addition to the cost of a regular CT, I'm guessing.
Absolutely.
Yeah.
Absolutely.
Yeah. No, this is an amazing talk. Thank you very much. Very comprehensive review and a great follow-up again, Dr. Buddha.
No, thank you for the opportunity. Thanks everyone. Take care. Bye-bye.
Thank you. Bye-bye.
Thank you. Bye-bye. I will move on to introducing our next speaker, Dr. Randerson Cardoso. Randerson is currently Chief Fellow in Cardiovascular Imaging at the Brigham Women's Hospital and Harvard Medical School. He completed medical school in his home country of Brazil, internal medicine and chief resident at the University of Miami, and cardiology fellowship at Johns Hopkins. He also obtained a master's in health sciences degree at Johns Hopkins Bloomberg School of Public Health. His clinical and research interests include the intersection between cardiovascular imaging and the prevention of cardiovascular events. In particular, he is interested in the use of cardiac CT to promote risk stratification and guide allocation of risk-reducing therapy. He's going to talk to us about the role of cardiac CT in atrial fibrillation. And my understanding is that he's going to be continuing on in Brigham as faculty after he finishes his fellowship. So congratulations, Randerson, and thank you very much for doing this for us.
Thank you very much, Dr. Ashraf. Can you hear me okay?
Yes, we can hear you.
We can hear you.
Excellent. So thank you very much. I also want to extend my thanks to the American College of Cardiology Iowa chapter, to the FIT Council. It's really an honor to be here today and present to you about the role of cardiac CT in atrial fibrillation. I have no disclosures related to this talk. And as you know, we're going to be talking here about a very prevalent disease. The estimated prevalence of atrial fibrillation currently is nearly 50 million individuals, and that's actually expected to increase over the upcoming decades to nearly double that number. Interestingly, atrial fibrillation is more prevalent in people of European ancestry. This is data from reported in the European Society of Cardiology AFib guidelines, where the lifetime risk of the individual of European ancestry for atrial fibrillation is 1 in 3 individuals. The risk is actually lower, but still significant in African Americans and Asian individuals also. And of course, that prevalence is expected to increase because of the aging of the population and then the increasing prevalence of risk factors for atrial fibrillation. So specifically, obesity, diabetes, sleep apnea, these are important risk factors for atrial fibrillation that have also had an increasing prevalence. So a highly prevalent disease, as a cardiologist, and cardiovascular imagers, this is a disease that will be very important in our practices. And then we're going to talk about how cardiac CT can help in the diagnosis and management of conditions related to atrial fibrillation. Specifically, I'm going to be talking about 3 points here, which is the use of cardiac CT to evaluate left atrial appendage thrombus, use of cardiac CT for catheter ablation, and then use of cardiac CT for left atrial appendage occlusion. And then it's very important part of this talk is image acquisition and protocol for the studies. And I'm going to actually talk about that last, just to keep the most high yield part of the talk, which is the clinical applicability of this in the first half of our conversation. So first, let's talk about the use of cardiac CT to rule out or to evaluate for left atrial appendage thrombus. And it's very simple what we're trying to do here. We're trying to fill the left atrial appendage with iodinated contrast, and then a filling defect is presumed to be a thrombus in the appendage. However, there's an important caveat here that everyone should be aware of, which is that the anatomy of the left atrial appendage with trabeculations, and then particularly slow filling, can lead to delayed contrast filling of the left atrial appendage, such that the timing of acquisition of coronary CT that we usually obtain for, of cardiac CT that we usually obtain for either coronary indication or a valve assessment where we have maximal opacification of the left-sided chambers, what we call the arterial phase, the maximum contrast opacification of left-sided chambers, that phase can have the appendage not yet opacified. As such, every time we're trying to evaluate left atrial appendage, which we're doing a study on a patient with atrial fibrillation, it's important to obtain a delayed phase where we're going to see the appendage fully filled about 45 to 60 seconds after that initial acquisition. So here's a few examples for us to review. This is an oblique view of the left atrium. And we see here the left atrial appendage. And as you can see that there's a dense filling defect seen here on this oblique view and also on the axial. And again, this is that arterial phase where the left atrium and the left ventricle are maximally opacified. And at the beginning of my training in cardiac imaging, I was used to be you'd think that this would be a thrombus, because it's such a dense filling defect but actually this can just be the delayed filling that I was talking about earlier. So it's important always to get a delayed phase when we're looking at the left atrial appendage. So for instance, in this other case here, you'd think that the appendage here is more of a windsock, a short appendage, but then on the same appendage, when you look at the 45-second delay, you can see that it's actually a chicken wing, and there was a dense filling defect here on the arterial phase. 45 seconds later, it's fully opacified, and there's no thrombus there. So again, the importance of getting this delayed image acquisition. Here's just another example, a more subtle filling defect here in the tip of the left atrial appendage, and then you see 45 seconds later, fully opacified. Now, this is an example now of a real thrombus where both on the arterial phase and then 45 seconds later, we see that there is a filling defect in the tip of the left atrial appendage. So how good is CT for this indication? Turns out it's really excellent. There's an excellent sensitivity and specificity of this technique as long as you add that delayed phase. If you don't add the delayed phase and you start calling the arterial phase thrombus, you're going to obviously decrease your specificity by a whole lot. And that brings me to a point I wanted to make, which is that even when you're doing a cardiac CT for another reason in a patient who has atrial fibrillation, let's say you're doing a coronary evaluation or you're doing a valve evaluation, TAVR planning, it's important to consider getting this a delayed phase, maybe just decrease the field of view, focus on the left atrial appendage. But it's important to get this delayed phase because often we're going to have this delayed filling on the arterial phase, and then you're going to leave the referring physicians and the patient in a worse spot before before the study was acquired, because the report might say something like, there is a filling defect in the left atrial appendage, it may be thrombus or delayed filling. And then they got to consider repeating a CT or getting a TEE to sort that out. So that's why protocoling is very important. And as fellows or rotating on an imaging service or whenever you're protocoling these studies, it's important. If you know the patient has a history of atrial fibrillation, just considering getting a delayed phase, even if the study is not specifically for the left atrial appendage. It's just something to consider, not mandatory. So back to the value of this is a meta-analysis of 27 studies involving nearly 7,000 patients. And on this meta-analysis, the authors found that the pooled sensitivity was 98% and the pooled specificity of the cardiac CT compared to TE was 100%, again, using that delayed phase. So this is really the best summary ROC curve that we're going to see for diagnostic medicine, where the sensitivity and specificity approach 100% for this imaging modality. And obviously, just the relative strengths of cardiac CT relative to transesophageal echo for this indication include the fact that it's less invasive, there's no risk of the esophageal injury related to the TEE, and you don't need the sedation. And of course, the downsides would be a small radiation dose, and the fact that the patient needs iodinated contrast, all of which, you know, are pretty insignificant, except in patients who may have allergies, for example. So next, let's talk about the use of cardiac CT in patients with atrial fibrillation for the planning of catheter ablation. And here's an example of a use of a cryoballoon for isolation of the pulmonary veins. As you know, this can be done with cryoballoon or radiofrequency. And this procedure, the catheter ablation for atrial fibrillation, is now recommended on European and American guidelines, even with a Class 2A recommendation as a first-line option for rhythm control in patients with paroxysmal atrial fibrillation, Class 2B in patients with persistent atrial fibrillation, and as a Class 1 in patients who have heart failure reduced ejection fraction with AFib. And of course, it can always be used as well in patients who fail drug therapy as a second-line option for rhythm control in patients with AFib. Same thing this is the American guidelines now, recommending again catheter ablation, even potentially as a first-line option for rhythm control in patients who have AFib and need rhythm control and potentially don't want to be on antiarrhythmic drug therapy, or as a second line to antiarrhythmic drug therapy. So there are a number of things that we'd look before catheter ablation with the cardiac CT. in patients with AFib. We would like to exclude the thrombus, which we already talked about, but also look at the number of pulmonary veins, the anatomical configuration of those veins. We'd like to look at pulmonary vein anomalies, if there are any, and then the position of the esophagus, which may be associated with esophageal injury if the proceduralist isn't careful and there's esophagus is abutting one of the pulmonary veins. So let's talk about a little bit about each of these assessments. This is a 3D evaluation of the most standard pulmonary vein anatomy with 2 left-sided and 2 right-sided pulmonary veins. But a very large proportion of the population has either a common trunk on one side or then 3 pulmonary veins on one side. So like in this example, we see 3 pulmonary veins on the right side. And that is, of course, important for the proceduralist to know for pulmonary vein isolation of all these pulmonary veins. Some caveats I'd like to mention here, which is the fact that it's important not only to look at axial images, but also look at oblique views of the pulmonary veins when assessing for that indication, when assessing pre-catheter ablation. Here's an example where you see 2 separate left and 2 separate right-sided pulmonary veins. But on this video I'm going to show you, you can see that sometimes you can have a really short trunk, a common trunk. As you can see here, these 2 pulmonary veins, these 2 left pulmonary veins, they touch each other and join the left atrium as a common trunk. So you can be fooled on this by the axial imaging into thinking that there are 2 separate pulmonary veins, when in fact there's actually a short common trunk, in this case, between the left superior and left inferior pulmonary vein. Another important finding on cardiac CT that has implications for the catheter ablation is the finding of a top vein. That's a vein from one of the upper lobes that joins the left atrium in the roof of the left atrium, also called the roof vein. And this top vein, it's usually trivial, but sometimes can be a large vein like this one here. And then, of course, would require separate ablation as well, because it can also be arrhythmogenic like the standard pulmonary veins. We also have the ability to fuse the CT, even MRI can do this, but fuse the 3D image acquisition from CT with electroanatomical mapping. And this has been shown over the last couple of decades, actually, that it reduces procedure time, reduces fluoroscopy exposure, and improves success rate of ablation. And then, as I mentioned, also important to look at the position of the esophagus. In this case, you see the more standard anatomy where the esophagus is adjacent to the left lower pulmonary vein. And it's important for the proceduralist to know the risk of atrioesophageal fistula is incredibly low. But again, that's because of improvement in technology, use of contact force sensing catheters and other things, but it's also because of awareness of this condition. So it's pretty standard to put in the report of the cardiac CT, the position of the esophagus relative to the pulmonary vein. Sometimes it's closer to a common trunk, and sometimes it's closer to the right-sided pulmonary vein, lower pulmonary vein. And also important, cardiac CT can be used for evaluation of another complication of cardiac CT, which is pulmonary vein stenosis. As you can see in this case, left lower pulmonary vein has a important stenosis over here. Pulmonary vein stenosis used to be much more common than it is nowadays. With the earlier techniques, used to do ablation within the ostium, and there was a high prevalence of pulmonary vein stenosis. Currently, the incidence is quite low. Less than 0.5% on some recent series, and such that there's no routine follow-up CT that's recommended post-pulmonary vein ablation, pulmonary vein isolation, to look at this as part of a screening. However, if patients develop symptoms, and we'll go over those in a little bit, this is, of course, the cardiac CT is an important test to evaluate for this complication. It's important to have heightened awareness, because even though it's rare, it's not, and it's a well-known complication of cardiac ablation for atrial fibrillation. Here's some risk factors Obviously, the small pulmonary vein size and then less operator experience has also been documented as a risk factor for this complication. The symptoms can be quite non-specific and similar to other cardiovascular symptoms or pulmonary symptoms. So it's important to have heightened awareness of this complication in patients that have had atrial fibrillation ablation and consider getting a cardiac CT to evaluate for this issue. In terms of this cardiac CT findings, there's no specific diameter that is a cutoff that make this diagnosis. The pulmonary vein's diameter obviously depends on the size of the pulmonary vein, and it's also very dynamic through the cardiac cycle. Most studies have used more than 50% reduction in diameter of a specific pulmonary vein as a diagnostic criteria. Also important to compare with the baseline study, pre-catheter ablation. And if you do that, again, the pulmonary veins do have a change in diameter over the cardiac cycle. So it's important to, if you do that, to look if you're in the same phase of the RR cycle, let's say 40% phase, which is a pretty standard phase in late ventriculars, in late systole to get these images. This is a series from Cleveland Clinic and more than 10,000 patients who had atrial fibrillation ablation during a 15-year period that ended in 2015. So a lot of these, the incidence was 0.5%, but a lot of these cases were with earlier technologies or in the 2000s. So nowadays, the incidence of this complication is actually much less than 0.5%. And the most common vein is the left superior pulmonary vein. And again, these are the symptoms that can be fairly non-specific, so important to have heightened awareness of this complication. There's a lot of different interventions that can be done for pulmonary vein. The most common one would just be angioplasty and actually stenting of the pulmonary vein. And of course, CT can help in planning of that also. Finally, we're going to talk about the use of cardiac CT for, we're going to talk about the use of cardiac CT for planning of left atrial appendage occlusion. And then later, we're going to talk about protocoling and acquisition of these studies. So this is becoming a more common indication for cardiac CT in patients with atrial fibrillation, which is to look at the appendage specifically for planning a percutaneous left atrial appendage closure. Over here, we have many indications for this, for imaging in this scenario. Of course, we're going to exclude left atrial appendage thrombus, which we already talked about. The CT can be used for planning the transeptal puncture. And then most importantly, sizing is really important. And then looking at the relationship of the appendage to surrounding structures like the pulmonary artery, pulmonary veins, circumflex artery, all can be compressed by left atrial appendage occlusion devices, even though those are rare complications. And then in some centers, this can even be used to print a 3D model that can guide transeptal puncture, catheter selection, and other things. So let's talk about how first to obtain this image and how do we go about sizing the left atrial appendage for percutaneous closure. So this is an axial view, straightforward axial. And you can see here the coronal and sagittal views. And then we would manipulate the multiplanar reformatting. And this is, again, the strength of cardiac CT may have been discussed in prior talks, that CT has isovolumetric voxels, and it's really easy and to do multiplanar reformatting and get oblique views in the structures that you're interested in. So we would rotate these crosshairs here to align it between the mitral valve and the left and the apex to get sort of an oblique view here of the of a two chamber. So essentially all we did here was drag the crosshairs here to the mitral valve and then rotate it so that it goes somewhat through the apex. And what that does is it gives you an oblique two-chamber view where you can see the ostium of the appendage. Once you have that, it's quite easy. All you have to do is drag the crosshairs to the ostium of the left atrial appendage like we do over here. And then at this point, what you do is standard practice in cardiac CT. Every time you want to obtain a short axis view of any structure, be it a coronary, aortic root, ascending aorta, every time you want to obtain a short axis view, you align 2 long axis views. So in this case, we align 1 long axis view perpendicular to the ostium of the appendage, do that same thing here. And what that does is on the 3rd view, it gives us a true short axis of that structure. And then we would measure this and get the sizing of the left atrial appendage. Again, this goes for a coronary, this goes for any structure in vascular medicine and cardiac CT. Every time you want a short axis of a structure, it can even be the ventricle, for example, you align it on 2 different long axes. So from this view here in the left atrial appendage, we would do the measurements for the percutaneous left atrial appendage occlusion. This is probably the most used device, which is the Watchman Flex. And just to point out some important characteristics of this device that's important that we consider when we do the cardiac CT. So this is a 2nd generation of this device. And the one important concept here that has changed from the 1st generation is that the device is more shallow now, so that the 1st generation, there are a lot of patients that were excluded because the appendage wasn't deep enough to have implanted a device that was previously much more square, in the sense that the depth had to be at least as big as the diameter of the Watchman. And now it's much more shallow. And now it's much more, and they also come in many different sizes, so such that few patients are excluded because of they're ineligible because of sizing, because there's no device that fits. So that was one important modification. And then much more important for the proceduralist, there are things like there's this hook that we'll see on imaging that allows for recapturing. But there's important for us on the cardiac CT side, there's a fabric covering that hook or that central structure. So such that if there's a small filling defect adjacent to that, I'll show you, then it's not necessarily a thrombus, or at least it's not exposed to the left atrium because there's fabric covering that hook. But I will show device-related thrombus where thrombus extends beyond that structure. And then there are some other things that you can see here in the slide, like it's a less traumatic, for example, compared to the 1st generation. And then the way we would do the sizing for this, I've showed you already how to get here to the left atrial appendage, but we would measure specifically at this location, going from the circumflex artery here to about 1 to 2 centimeters into the ridge of the left atrial appendage. That's just the way that this particular device is implanted. And once we get that short axis view that I talked about previously, the short axis longest dimension is used for sizing. So for example, if you get a 23 millimeter device, you would then, 23 millimeter diameter, you would then go with a 27 or a 31 millimeter device, because there is a little bit of compression that's necessary to hold the device in place. And then we would also get this depth and length of the left atrial appendage. And as I was mentioning before, the shallow depth used to be a problem, but no longer with the modifications in the shape of the device. This is another device that's available, the Implantier Amulet for left atrial appendage occlusion. And then it's got a slightly different technique. It's measured a little bit further into the left atrial appendage. This is something that's worth mentioning, highly talked about in cardiac CT evaluation of the left atrial appendage, which is the different morphologies of the left atrial appendage. There's this more windsock morphology where it's just a long cylinder, chicken wing that similar but has a clear distinct bend in the middle of the left atrial appendage. A cauliflower morphology has that short cylinder, but then distally has many different secondary lobes, such that the distal end is going to be longer or wider than the more proximal tubular structure of the appendage. And then a cactus is similar to the cauliflower, except that these secondary lobes start very proximally. And the practical implications of this, there's a couple that's important to be aware of. The chicken wing morphology is the one that's least associated with stroke. So non-chicken wing morphologies are associated with higher stroke risk. but that's only a slight association and not necessarily any different type of management will be done differently. But then specifically for left atrial appendage occlusion, if the appendage morphology is chicken wing, it's important to mention, to evaluate the distance to that bend in patients who have this type of morphology, because that'll be important for planning for the Watchman. This is used, the data from CT can be used to plan for even the transeptal puncture and deployment of the device with 3D printing. I'm not aware of many centers who are doing this clinically, but there may be. Certainly can be done with the CT data. Because this would allow a better choice of the catheters. For example, there are different catheters that can be used to deliver the device, and it's important to be axial with the left atrial appendage. And planning the transeptal anatomy and looking at the left atrial appendage morphology also, and doing that with 3D printing is an advantage. But then this also remains to be not yet used widespread clinically for sure. The cardiac CT can be used routinely to follow up post-left atrial appendage occlusion. So typically, patients will have a cardiac CT to be done 45 days or a transesophageal echocardiogram. And on that follow-up CT scan, for particular things that we'll be looking at would be compression of any adjacent structures by the device. Peri-device leak, we're going to talk about that, where there's still a opacification by contrast of the left atrial appendage, or any device-related thrombus. So here's the proximity of the Watchman to main pulmonary artery, to circumflex artery, and these are very rare complications where you get compression of an adjacent structure, but certainly that's something that can happen, especially the circumflex artery. And it's important to keep in mind every time you're evaluating the compression by especially a device in cardiac anatomy, in the coronaries, it's important to evaluate dynamic. So it's important to obtain the full RR cycle or a large width of the RR cycle, because compression, for example, of the coronary can be dynamic throughout the cardiac cycle, much like a myocardial bridge, for example. We can think of it that way. So generally, when we do appendages evaluations for thrombus, you can even acquire just a single phase, just one point in time in the RR cycle, but not when you're looking for this particular concern of compression of an adjacent structure. And then the most important point that we'd like to evaluate with these 45-day CT scans that are done routinely is whether the occlusion worked, whether the device is fully opacified, fully excludes the left atrial appendage. And you can see here when there's a nice seal that there's no contrast filling of the left atrium appendage. And yeah, this is a perfect seal. Now, having said that, it's quite common, unfortunately, that we do have residual opacification of the left atrial appendage. And that has been defined by a lot of studies of either a Hounsfield units that's above 100 in the left atrial appendage. In this case, it's above 600, so it's clearly opacified. Or when the Hounsfield units of the left atrial appendage is more than 25% of the Hounsfield unit of the left atrium. So in this case, clearly opacified appendage, it's still opacified, so the appendage is not fully excluded. And there's basically two reasons why that could be. One reason is that there's a peri-device leak. I'll show you that in a second. And then the other reason, if there's no leak, it could be that there's just no peri-device leak. It could be just that there's a fabric leak. So in terms of, just before I show you those examples of peri-device leak, it's an important discussion here is just how sensitive CT is to finding these leaks. So some series, they report, as much as 50% of patients post-Watchman or post-left atrial appendage occlusion still have filling or contrast opacification of the left atrial appendage. And that has raised a lot of questions about, using of one modality versus another, or more importantly, about clinical implications of these leaks. I'll talk about that in a second too. So one possibility is that you just have a peri-device leak. The Watchman is here, and then there's a peri-device leak. And again, about just how much more sensitive CT is than TEE, you can see not only the transverse dimension of this, but you can see the full extent of the leak. And this could also be done with 3D TEE, but then you get into issues of variability between operators, which is much less of a concern with cardiac CT. So with cardiac CT, we'd measure the narrowest width of that leak. Like in this case, it would be like a 3 millimeter leak. And then it's important to talk about the clinical implications of that, especially given how sensitive CT is. So as you may know, there's this standard 5 millimeter rule that was established very much arbitrarily in the initial studies of Watchman, using TEE, of course. So this is a recent editorial on this topic in JACC EP, and the author here writes that, and I quote because it's such a really well written, it says that this finding that smaller peri-device leaks do not seem to be associated with an increased event rate come really from small cohort of patients, and they've been very convenient for the device industry and eager operators. However, we're talking about an event rate here in patients who have atrial fibrillation. Even if you disregard the occlusion device, the event rate might be around 4 or 5% a year. So there's a big challenge here, which is the fact that the event rate is low overall stroke rate. You would need a very large population to be studied prospectively with a long follow-up to conclusively prove that small leaks are of no concern. And with that in mind, the author also reminds that this cutoff of 5 millimeter to separate benign leaks from those that require continued anticoagulation is very much arbitrary. And then there's really not a lot of data to support it, specifically in the context of cardiac CT, because again, much more sensitive technique. There's a wide variety of techniques that have been used to close these leaks. One particularly interesting one that's been reported recently with good results is the use of radiofrequency ablation. So ablating the atrium side close to the leak, as you see in this case, in this good example where it seals the leak. So essentially creating tissue injury with radiofrequency can seal the leak. And these authors report, I think in 43 patients, a median leak that went from about 5 millimeters pre to really a majority of patients having a complete seal with this technique. I think they decreased their 50% of patients who underwent this had a complete seal, and then about the other half had decreased to like 1 or 2 millimeters. But again, the clinical implications of that is something that we still don't know, whether a 1 millimeter, 2 millimeter leak is safe to stop anticoagulation. And it's something that remains to be answered in future studies. As we finish off the gamut of complications are related to these devices, an important one is that device-related thrombus. So here's that metallic structure I was telling you about that allows for recapture of the device and makes it easier to implant these. On the other hand, it can this structure is, I also wanted to mention, it's covered by that fabric. So if you see like a tiny hypoattenuating density here besides that metallic structure, that's endothelialized. But the problem is in this case here, you see this hypoattenuating structure that extends here far beyond that metallic structure and goes all the way into the left atrium. So this represents a device-related thrombus, and it's not just that condition where it's covered by the fabric. Here's another example on the actual hook. You almost raised the question whether this metallic structure is serving as a nidus here, because this thrombus is so well organized and formed on top of it. This patient also had this other larger thrombus here adjacent to the device in the left atrium aspect. So some risk factors for device-related thrombus post-procedure are hypercoagulability, renal insufficiency, patients who have permanent atrial fibrillation or persistent atrial fibrillation, and a very big, larger implantation depth from the edge of the appendage, from the pulmonary vein edge. Finally, to wrap up this talk, let's talk about patient preparation, a more technical aspect of this talk at this point, and this will vary by location. I'll try to highlight the most important points for acquiring these images. The most important one for patient preparation, I'm sure you will hear this also in the coronary talks, but patient preparation is really key. And because the injection rate is usually 5 milliliters per second, you don't need to inject 6 or 7 or these higher rates unless you're doing a concomitant coronary too, of course. So you can do an 18 or 20 gauge IV as long as it's a good IV. And you can, it can be anticubital is preferred in case there is an extravasation. It's a safer location for that to happen. This is really important, and as a fellow, we prepare patients, and we're available at the scanner. And I have something that I learned that can really improve image quality, and it's important that the technologists are aware of this, is to give a patient a heads up that they're going to receive the contrast infusion and practice breath holding with the patient. These really can make or break in terms of getting a good image quality for your study, and frequently underrated how important these are. And then also important to talk about related to cardiac CT acquisition as a whole, not just for a left atrial appendage evaluation, left atrial evaluation, but also for coronaries, for anything really, is the two different ways that we can provide gating for these studies. So one way would be to just scan nonstop until you acquire all the coverage that you need, and then have the gating going in the background. You're basically acquiring the QRS data, the RR interval data, and then when you're done, you retrospectively go and attribute specific image acquisition to a certain amount of a certain period in the RR cycle. That's called retrospective gating. Another way of doing it is to actually trigger acquisition of the images based on the QRS interval, on the RR interval. So essentially the scanner looks at the prior RR interval, and then you've predetermined, for example, that you're going to scan 65 to 80% of the RR interval. So it looks at the prior RR interval, triggers at this point, and then waits until what it thinks will be 65 to 80% of this RR interval based on the prior one, and then acquires imaging at that point. The biggest advantage of prospective gating is, of course, less radiation. You can clearly see that this radiation is a lot less when you do prospective gating. The problem with prospective gating is that you really suffer from arrhythmias, because if this RR interval is different than the next one, what you thought was going to be 65 to 80% is actually not, especially if you have a scanner that doesn't have full coverage, but does what we call what step and shoot is a term that's used for this. Basically, you have to stitch together different acquisitions, and then what you end up risking is misregistration artifacts if your RR intervals are different, if the heart rate is irregular. Now, for the appendage, this is obviously most patients will be irregular. They're in atrial fibrillation. The RR interval will be irregular. But for most patients, that's not a problem for the appendage, as long as it's not super fast and irregular, because what happens is that the appendage moves much less than, for example, the coronary arteries in the atrioventricular groove. So we actually scan in our site, we scan prospective to save on the radiation, as I was talking about. Unless, of course, that the patients are really fast, and then we can even do non-gated in those cases. Of course, you run the risk of having impaired image quality in those cases. But usually you get away because the appendage moves a lot less than the coronaries. So a couple other things about this CT protocols to wrap up this talk. We do, and this again, this is our site, it may vary from site to site. We do our scans at 75% phase if the heart rate is low and you have long diastole. But then if patients are fast, the phase that's usually has less motion in the cardiac cycle is end systole, so we usually go to 40% phase. From my review of the literature, most centers will do anywhere between 40 and 70% phase for these studies when they do prospective gating. We don't need beta blockers or nitroglycerin unless you're, of course, doing a concomitant coronary evaluation. Don't forget that 45-second delay that I was telling you about earlier. And then the biphasic injection is always important because you give contrast and then you give a saline chaser that really keeps the contrast bolus homogeneous and minimizes streak artifact on the right-sided chambers. The energy, Dr. Budoff talked during his talk about coronary artery calcium being at 120 kV. That's, you can think of that as the energy of the photons. It needs to be 120 for coronary calcium. But for coronaries and for coronary CTAs, for appendages evaluation, you can really, with modern scanners, you can use the automatic attenuation of this. That's automatic choice of the scanner, and that choice is based on the attenuation map on the pre-monitoring scan. So if a patient is obese, for example, you're going to need higher energy photons, and that kV is going to be 120, for example. If it's a thin patient, doesn't have a lot of soft tissue attenuation, it may drop down even as low as 80 or 70 kV. So those are some more technical terms, but important to discuss these protocols to get good image quality. I want to thank the Iowa Fit Council again for this invitation, and I have my email here. I'm happy to answer any questions now, or also later on, if you want to shoot me an email, I'd be happy to chat about this. Thank you very much.
Thank you, Dr. Cardozo, for such a very thorough and comprehensive talk. That was actually really educational for me, at least from the planning and CT and things like that. I didn't realize that how much the delayed phase adds to the study. So thank you for that. We do have one question in the chat. So could you comment on the reproducibility of the landing zone area measurement for Watchman specifically? The JACC paper referenced in the talk and another circulation paper mentioned a 1 to 2 centimeter plane from the circ to the Coumadin ridge, which I believe introduces some variability. And then also, is the Watchman size selected from the osteal diameter or the landing zone diameter?
Yeah, those are good questions. Let me go back to the slide on that. This is actually from a JACC. I don't think it's the same one that's mentioned there, but this is, no, this is one I have to still review, the one that's mentioned in the chat. But this one is a state-of-the-art paper from JACC-EP on how to make these, the correct measurements for the Watchman and actually for other devices as well. But for the Watchman, the recommended approach is to find the circumflex artery and use the circumflex as a landmark on one side, and then go about 1 to 2 millimeters into the ridge here on the other side. And the person, Mohammed, who made the question, I think he made, sorry, someone else, made a great point about the variability. I'm not aware of specific data on variability. I can say anecdotally that certainly when the reader experiences less, I can see this from like my own experience and from fellows in training, that that there is a significant variability. But as I progressed in my training and also seeing other colleagues and looking at my attendings, for example, that I think that it's very, it's much more reproducible. Having said that, again, this is very much anecdotal. I'm not aware of data that talks about specifically inter-reader variability for this indication.
Awesome, thank you. And then, yeah, like you referenced there's a post in the chat about a recent article from April in JACC-EP on the impact of residual leaks, if anyone's interested. And then I guess I just had a general question. So the importance of the delayed phase, you obviously did a great job showing why that's important. Is that equally as important when you're doing the follow-up CTs? You know, in case you're missing something downstream. Okay. Yeah,
absolutely. It's a great point, because of that. The same thing about talking about the opacification of the left atrial appendage. You can also have delayed filling of the contrast in the left atrial appendage from like a fabric leak, for example, related to a fabric leak can lead to filling of the left atrial appendage more delayed. Now, having said that, the clinical implications of that and what do we do with an appendage that doesn't fill in the arterial phase, but fills in the delayed phase 45 seconds later, you know, I think it's unknown at this point. But certainly from a protocoling standpoint and image acquisition, we generally do, we perform these studies in the same way, and we get a 45-second delay every time we're looking at the appendage.
Awesome, thank you. I don't see any other questions coming up in the chat, at least right now. Dr. Ashwath, do you have any questions or any other insight?
I just want to thank Randerson. That was a great talk, very comprehensive review. For the viewers, Randerson was recommended by Raymond Kwong when I tried to see if he was available. He said, I have a great speaker available, and of course he was totally right about it. So thank you very much. That was a great talk. And again, congratulations on finishing up your fellowship and moving on to a great position, and all the very best to you. I just wanted to take this moment to actually thank my FIT Council for, we had some unexpected changes in the FIT Council early this morning. So one of our FITs had a family emergency. So please keep him in your prayers. But I had Michael and Sapide step up about 2 hours before the talks. That's when we were messaging and trying to coordinate and see who would moderate and who would be available. So they, of course, did this perfect job and put the show on completely perfectly. So thank you very much, and I appreciate you all showing up on this long weekend, participating and in this conference. So look forward to see you all again. I just wanted to show one thing. We do, I don't know, can you see? Yeah, I think you can see. We do have our, the lectures posted on the Iowa ACC website. Whenever the recordings are done and ready to go, you can see from the last couple of weeks, and then, the next week's sessions will be coming up soon. Under fellow education, again, we have the general board prep lectures, interventional cardiology, and the echo board prep lectures that we did last year. So feel free to share them with your colleagues, and feel free to use them as needed. And thank you all again for joining. Enjoy the rest of the beautiful weekend. Thank you.
Thank you, everyone, for joining, and thank you for your participation and great questions. Have a great weekend.